moderator, Dr. Harpreet, all the teachers and the students. Today we have the second session of urolithiasis. What we like that all are doing very well. We have two messages to pass on. One, have
Alexa,
a safe surgeon. We practice as a safe surgeon. We stop where you can do the, otherwise don't over enthusiastic damage the things, and take the help of your seniors in case you need it. Always keep the patient first in mind, and whatever complications, record it, take help, he will be all right. So these two things, you are going to be a consultant, and our best wishes with you. But these are the things which you are learning, which you are going to practice as in safe and have some new things which you want to add in your mind. Ask question freely, which you expect that will be asked in the exam, or the difficult, you are not clear. We are all ready to help you. So with all these words, I just hand over the mic to Harpreet. Over to Harpreet, moderator.
Thank you, Ranveer sir, for this opening. Thank you, Ranjanda. And again, I told yesterday, it's not easy to run such a program in such a scale. I really appreciate the council, especially the efforts taken by our president, Ranveer sir, and the Ranjan. Ranjan sir has done a lot of hard work, and we have seen the success of this program last year also. And thank you, EZUSI, for giving us this opportunity. And sir, as you have mentioned, the now buzzword is safety of the patient, and if the patient is safe, we are also safe. So I think swallow your ego, swallow your pride. There is no problem. If the patient is living, you can always come again. I totally agree with Ranveer sir that is the way forward. ऐसे भी कहा जाता है safe endourology करने की जरूरत है. And in these 4 cases, which different scenario has been given by the John to us, that will be our motto. I'll just take a quick attendance. Dr. Amit is there. Dr. Sonu Patidar is there. You're going to take first case. Then Dr. Tehzeeb and Dr. Arif is there. They will take the second case.
Yes, sir. Dr. Arif. I am Dr. Arif, sir.
Where is Dr. Arif? Please. Arif, okay. Dr. Tehzeeb Alam. Is Dr. Tehzeeb there? Anybody? Dr. Vaibhav? Is Dr. Vaibhav there? Good morning, Shivajida.
Good morning, Ati. Yeah,
good morning. Dr. Vaibhav there?
Yeah, Vaibhav, answer.
Dr. Swati Khatri and Dr. Jayad. Morning, Paul sir. Morning, Rahul. Morning, Sandeep. Morning, Nitesh.
Good morning. Good morning, everyone.
Right. So I think the first scenario, which has been first, we have the Nirmalya. In the meantime, I may call the people from the Dr. Tehzeeb is not there, na? Nirmalya, can you call Dr. Tehzeeb, because his case is second, he still have time. And then Dr. Swati Khatri and Dr. Jayad, are they there? They are the last case. So Nitish will start the first case. The first case scenario is Staghorn calculus in a 67-year-old lady with a recurrent UTI. And Amit Ranjan and Sonu Patidar will take the first case. So what I will request, once Nitish has presented the brief case, residents have to ask what they want more, what they need next. And anybody can ask question apart from our teachers like experts, Shivaji Da, Pal sir, Ranveer sir, Ranjan Day, Sandeep is there, Rahul is there, myself is there. And if anybody resident also has a doubt, sometime in the videos we're not able to see the hand, can you raise your hand and you can ask? We'll definitely, if the idea is not to monologue, idea is to have a dialogue and to discuss small things in a big scale time. So with this scenario, And this brief, good morning to all of you, and we're going to start the first case. Over to Nitesh. Nitesh, you will present the first case?
Yes, sir.
Right, great. Go ahead.
Good morning, everyone. This is the first case scenario. 67 years old female is a housewife occupation and comes with a chief complaint of left loin pain since 1 year. She was relatively symptom-free 1 year back. She developed pain, which is mild, moderate, radiates to back, lives on medication, and she has a 3 episodes of burning micturition, mild urgency and frequency in last 1 year, which was relieved by antibiotics. And no other features like fever, pyuria, voiding difficulty, lithuria, decreased appetite, nausea, or vomiting. She has no any history of urolithiasis or stone disease in the past. She is diabetic for 5 years, hypertensive for 5 years. She is a coronary artery disease patient. She had an angio and stenting 3 years back, and she is on dual antiplatelets now. There is no history of COPD, allergy, other things, no blood transfusion. Hysterectomy was done 15 years back. She is married, 2 children, normal personal history, nothing significant. Examination, BP is slightly on the higher side, rest everything is normal. Abdomen palpation, nothing is abnormal. So with this history, what do you like to do next?
Hello, sir. Good morning. I'm Dr. Ahmed here from
Yes.
GMCH Guwahati. Sir, I need to know more about the chief complaint of the pain in the loin. I just want to know that it's a continuous pain or intermittent pain, whether it is associated with hematuria or a change in position, whether it is radiating or not, whether it is colic in nature or it's stabbing in nature. Sir,
It's a dull aching pain. It's non-radiating. It comes and goes off and on.
okay, sir. And whether it's associated with any prior history of any LUTS, whether the patient has a history of taking a medication, whether she has went for the.
Amit, just there's a lot of background noise. I request everyone to who are not participating, mute yourself, please.
Sir, patient has a history of history of taking a medication for only for the burning maturation. Whether she has went for the hospital for any investigation, whether she has a similar history in the past of the same complication, whether the urine culture earlier urine culture has been done or not, whether it's first time she has came to the hospital, and also.
There were 3 UTIs, symptomatic UTIs, for which she has taken treatment. And there were some investigations done, ultrasound. She was taking some local homeopathic medication, but she didn't turn up for the surgery or to any other hospital. So she was doing well off with just treating the UTIs.
And the diabetes, she is a known case of diabetes mellitus.
Yes,
Whether it's
diabetes and hypertension and coronary artery disease also.
The diabetes is controlled, or she is just on the
diabetes is well controlled. Hypertensive is almost borderline, and that's also controlled. That might be anxiety.
Now she doesn't have any history of lithuria, no history of any prior surgery. So we want to go for the forward as all the general examination and the systemic examination has been done. So now we want to go for the investigation with my differential diagnosis is generally the first is the stone disease, second is the any cystic disease or any infection, UTI may be there. So I just want to go for the further investigation on this patient.
What would you like to investigate? And one more thing I didn't mention, you should be cautious about the BMI also.
Yes, sir.
The history, but BMI should be taken.
And patient's menstrual history is also not mentioned, sir. So
good observation. So how would like to investigate this patient?
Sir, first I will go for the urine routine microscopy and urine culture. Along with that, I want the basic blood investigation, which consists of the CBC, RBS, RFT, and if possible, the serum calcium level and in this patient, and uh, further sodium potassium if possible, and then with the extension of the investigation, I will want a routine USG KUBs for this patient.
I'll give the results. These are the normal blood profiles you asked for. Everything falls within good range. Hemoglobin is 10.2. Electrolytes, sugar is 123. It's at well controlled. INR is also good. Calcium, phosphorus, uric acid, LFT, KFT, everything is normal. And this is urine analysis.
So the patient is E. coli is positive, and the urine analysis. Sir, I want to know more about the urine analysis, sir. Yes, sir. What the crystal is saying nil, and the pus cells is present. What about the bacteria, sir?
The bacteria, there was no bacteria on a clean film, but cultures are positive.
And the pH is normal. Okay, sir.
Yeah, pH is.
Yes.
ये तो ये वाला ना कल का यूआरएस बायोप्सी
This is the USG
डिस्कस
that you asked for.
पीयूसी निकाला डिस्कस करो और ये नहीं अबे कौन irrelevance
Please mute who is not participating.
Mute yourself. Other those who are not participating, please mute yourself. Other participants who are not in the talk, please mute yourself.
6th लाइन
Dr. Kishore.
निकाल
Dr. Kishore.
There are two persons involved, right?
Yeah.
Yes.
The voice is from Dr. Kishore.
Sir, the ultrasound is saying that left stack on.
Technical team mute Dr. Kishore.
ଘରକୁ ଯିବ ଆରେ ତମକୁ ମୁଁ କହୁ ତମେ ମତେ ପଚାରେ କଣ କହିବ ତମ ଘରକୁ ଯିବ କି
Voice is
Where is this noise coming from?
yeah, it's done. Continue.
Please mute
It's from
yourself.
Dr. Kishore's mic.
Ruma, Nirmalya, mute everybody who is not speaking or who is not participating. Ruma, Nirmalya, mute everybody who is not in the participation here.
Okay, sir.
Yeah, it's done. Continue.
Yes,
This is the
sir.
ultrasound you asked for.
Yes, sir. Sir, I want to see the film once more, sir, if possible, sir. Okay.
This is the bladder.
Yes, sir.
This is the right kidney, and this is the left kidney.
Okay. Yes, sir. Yes, sir. Okay. Yes. Same, sir. Thank you, sir. Sir, as it's written, so, and it's obvious with the ultrasound film, sir. There's a one large stagon calculus present in the left renal PCS, and the extension is I can't see in the calysis, sir. And there's a no hydronephrosis is seen. So I want to see the further delineation and the PCS conditions, sir. So I want CT urography in this patient, if possible, sir.
Yeah, before we shift to CT urography, I would like to ask you what are the things you see in this film? What are the typical features for which you identify the stone? And what other things you can get, other information you can get from an ultrasound in the cases of stone disease?
Sir, there's a one sir, there's one stone which is present in the pelvis system, sir, with the acoustic shadow we can see, sir. The length, sir, about half of the kidney is more than, almost like 6 centimeters, sir, if not. And I can see if it is a.
It will be measured. Whatever, it's just a picture. It's okay
Sir,
that you mentioned the posterior acoustic shadow. This is the most
There is a
pathognomonic
post-acoustic shadow.
stone
yes,
disease.
Posterior acoustic shadow.
yes, sir. Posterior acoustic shadow is there.
Shadow
No,
is there.
no hydronephrosis is there. The parenchyma thick is looking normal, sir. And
And it just goes on a theoretical question. What other information would you like to gain from ultrasound? Suppose we are giving an ultrasound, or you are beside a sonologist or a radiologist. What are the things you want, you expect from the ultrasound report? Or the other things you can get the information that will help you in your surgery?
sir,
Cortical medullary
the
differentiation.
corticomedullary differentiation
Differentiation.
and the cortical enhancement, sir. If the is more in the, if there is a kidney is in the chronic kidney disease, the enhancement is more enhanced, sir. So now it's a normal looking, sir. I don't think any
Yeah.
kidney
The
disease is there.
few things I would like to highlight that
Sir,
you said about
cortical.
corticomedullary differentiation, the cortex and everything. While we are doing a PCNL, if you are good with your ultrasound, you are doing your ultrasound, you can see the position of the colon also. And you can
Yes, sir.
see how is the bowel related along with that. And with this practice only, we'll try to learn how to differentiate bowel, how to differentiate the kidney. So you have to either stand beside your sonologist or you have to practice. The other information you can get is about splenomegaly and liver, that what they're large or small. And the male patient, you can get other information about the lust. You can get the information because bladder picture is given for information that whether cystitis is present or not, whether the blood walls are thickened or not. All the other information you can get it from here. Even you can see the size of the kidney. You can do a Doppler if you want, and you can see the upper ureter, pelvis, PUJ, everything. So moving on next.
Sir, I want a CT urography in this
Yeah.
patient.
Which of the things you would like to go for? IVP or a plain CT or a CT urogram? Given an option.
Sir, if I
Sir, in
have
this case,
all these
I will
options, sir, I will go for the CT urography.
CT urogram.
Question from the panel. In the current scenario, which is the investigation is recommended? Whether a functional study is recommended for all patients? We had this discussion in urolithiasis meet. So just for the clearance, if any one of the seniors can chip in.
Nitish, if you're going to intervention, absolutely you need to see the function. There is no doubt. When you're going for a diagnosis, non-contrast CT scan is also good enough. Wherever it is not possible because of the race, creatinine and other things, you can go for the plain films. But wherever is possible, you can document the functions. Better to document the function. This is basically a teaching session, and let's not confuse. Wherever possible, to postgraduate students should reply that they need a contrast film. And I see Ranveer says Mason, the chat box very clearly has written, if it is not able to do it contrast studies, you can do plain CT as well, DTP arenogram. And at times the other one method is also to see the function is to putting a PCN. We are not getting into that. That's a different discussion altogether. Rahul, you want to add anything?
No, absolutely fine. The only thing is that all the radiological investigations are available. Now, which one as a candidate, not as a consultant, which is the first investigation of choice and why?
Sir, the CT urogram is, I think, sir, it's a better choice, sir, because
why?
it is giving the whole of the condition of the kidney, ureter, and the bladder, and the other associated organs also, along with the
other
function.
Patient has come to you for what?
Sir,
you are a urologist. What other organ you want to see in the patient?
Sir, the other side of the kidney, sir.
Other side of the kidney, okay.
Yes, other kidney, sir, and the
Sir,
function
other
of the
pathology.
it also.
No, one by one. Other associated. We are first. Let Amit answer, then I will come back to you. Okay,
sir, it also gives us the benefit of the seeing the function of the kidney, sir, and the drainage. If we
Okay.
are giving the urogram, we can see the drainage and any obstruction, anything.
Sonu, what do you want to do? Other associated pathology mean which associated pathology you're thinking in a patient of kidney stone? What would you like to find?
Sir, to rule out any other abdominal pathology. Any bowel pathology.
Bowel pathology. What is the incidence of picking up a bowel pathology with kidney stone? You are in which year?
Sir, third year, sir.
Third year. So you would have in your center you do PCNLs or kidney stones. You see, how much would you have seen in your logbook? How much in the OPD? How many you would have seen?
Sir, I will.
No. Just see. This is how you dig your hole. So in your 3 years of career, 365 days in a year, or almost 900 days, you would have seen at least 100 cases of kidney stone, at least.
Yes, sir.
In those 100 cases, how many people had bowel pathology with kidney stone?
So very rare.
Rare. So why do you want to get into a hole? So this is not the aim why you want to do a CT urogram. The answer would have been different. But if I tell you I do a IVP, so what Amit said is I get a lesser cost, lesser exposure, radiation exposure. I get all the information what Amit wanted on a CT urogram, but I will not get one information, which is very important for me in treating the patient. What is that?
Sir, hospital units, sir, of the stones.
That is of no
retrorenal colon.
That is for academic purposes. Even if you, whatever laser or lithoclass you will use, from practical point of view, it will break all the stones. You do not change your energy source depending on hospital unit. If you are doing a thesis, then it is fine. But on practical purposes, as a consultant, it will not make any difference. But one thing is there which CT will give and which IVP will not give.
So retrorenal colon.
Yeah. So the relationship of the colon to the kidney will be visible only on CT urograph.
CT.
Not be visible on this thing. So if you were given one single answer, I would have accepted your CT scan. Otherwise, CT has no added advantage over intravenous pyelography, which is a simple test available, easy, cheap. It is in all medical colleges, all hospitals, it is available. So that is the reason you want to do the CT urography to patient the colon. Okay.
So to sum up what Rahul has told, just not to make you any further confusion on this, even IVP is a good answer. You should be able to reason it. Your CT urography is a good answer. You have to reason it. Whatever you say, stand by it. And second thing, whatever you're doing in your hospital, that's what he's saying, that 3 years you have seen what is the methodology followed in the hospital. Just say that. Don't try to deviate and dig your grave. जो करते आ रहे हो, जो तुम्हारे bosses सिखा रहे हैं, वो गलत थोड़ी कर रहे हैं. They are doing it day and night. Just you have the reason for it. So stand by it. Rahul is smiling. So whatever you're doing, just say that. You will be safer that way. You will be able to defend. Your even boss is able to defend you and with you what you're doing in a hospital.
So what are the contraindications of doing an intravenous urography or CT urography?
Yes. That question I wanted.
I've got a question for Amit.
Yes, sir.
What sort of range of creatinine you will do this is a diabetic patient. We will do the.
I'm asking, what are the contraindications for doing the CT urography?
Sir, generally we are going for the 1.3 to 1.5 centimeter. Serum creatinine level 1.3 to 1.5. Sir, less than 1.3 to 1.5. Sir.
What 1.3 to 1.5?
Sir,
what is the range? 1.3 to 1.5. What do you mean by that?
So sorry, sir. 1.5 maximum level, sir. I can go for the CT, sir.
So if it is a 1.5, can you do a contrast study at all? If you have to, not in this maybe, whether in the IVU or contrast CT urogram, you have to put a dye and 1.5, can you do it? Or you will say, I'll go for MRI?
Sir, 1.5, sir, with the good hydration, we can go for CT scan, sir.
Fine. So that's the thing I wanted to know. And stop metformin before you do that one.
Yes, sir.
That's a very important message. In fact, Campbell also makes it. So good that this is brought in.
Some precautions as a clinician you will tell because he is your primary patient, he's a diabetic patient, he's a slightly aged. So what precautions you tell the patient before going for the IVP? And if you're very cautious, what would you do? If the creatinine is marginal, so how do you prepare your patient for a contrast study? IVP is not an issue.
Before IVP? Sir, before IV, we start IV fluid and hydrate the patient.
IV fluid?
Sir, hydration, proper hydration by oral.
It is fine, but you can't say IV fluid.
Yeah. And after IVP, we also put patient on the oral hydration adequately. And we ate some N-acetylcysteine agent and all this.
Very good. At least you know N-acetylcysteine, but what is the protocol of starting or giving the N-acetylcysteine in slightly high-risk patients? What is the protocol? When do you start? What is the dose? And how do you give it?
That's 600 mg.
Once a day, twice a day, thrice a day, 4 times a day.
Sir,
10
sir,
times
1
a
day before. Sir, we start 1 day before.
Twice a day, sir. We usually give twice a day.
Twice a day, 1 day before.
Exactly.
And
so at
1
least
day before,
24
you
to
continue on the
48
day.
hours prior to this thing and continue for how long after the IVP? Or you want to stop it just
next 24 hours, sir?
Sir, next 24 hours after 1 day.
24 to 40 days. Yeah.
Yes.
Or almost for 3 days. 24 hours before and 2 days after, or 2 days before and 1 day after. So what is the literature support for that? You've heard it or you've read it also?
Sir,
does it really
as per
help?
guidelines, there is no strong recommendation. It's weak recommendation.
Exactly. As per guidelines, there is no strong recommendation. But if the examiner is asking, this is what is expected of.
Yes.
So this is what the EU guidelines says, that whenever you can, you should perform a contrast imaging, pre-procedural imaging. But if it is not possible, it's okay to perform a RGP before going for a procedure. All you need to know is the anatomy of the stone. And for the function, they have not said that much. So this is the X-ray KUB.
Dr. Nitesh, I want to make a point.
Yes, sir.
Dr. Pal here.
Yes, sir. Good morning, sir.
Good morning. Good morning, everyone. In this particular case of a 66-year-old female, if the renal parameters are normal, I would like to go for a CT urography just to see the window, depending upon the hepatosplenomegaly and how the spleen is covering, particularly it is left side on the kidney, from wherever I will be able to make the approach. Secondly, it is only CT urography which will tell me the position of the stone within the system in anterior calyces or posterior calyces. If a staghorn stone is there, IVP will not tell me whether they are in anterior or posterior. It's only transverse cuts of the CT urogram will tell me. Thirdly, functional assessment is not so mandatory. Whatever it is in 66 years old, I will try to preserve the kidney. So I will not go for DTPA. Even if there is a small amount of function, I would like to save this kidney, give it a chance by removing the stone and the infection. So these are the points. I will do CT urogram if the creatinine is below 1.3. I will not hydrate the patient because any hydration will dilute the concentration of the contrast in the pelvic calyceal system, and anatomy and hydrocalicosis may not be able to be visualized. In ultrasound, we did not see any dilated calyces. At the same time, I will be trying to see if any calyce gets opacified nicely, which will be my parking spot for the guide wire for the initial puncture. So for all these reasons, I will go for CT urogram. Thank you.
This is the plain X-ray KUB. And this is the IVP, 5 minutes. So, Amit, would you like to comment on this? What do you see on the IVP at 5 minutes?
So at the 5 minute, the contrast is coming and filling the both the right and left pelvic calyceal systems. However, it is not going to the ureter, sir. We can identify the calyces, and with the cup is also good, sir. There is no any hydronephrosis. However, the radio density is there, sir, in the PCS.
Calyces seem slightly dilated, and you can also notice on the opposite side. Could you notice anything?
The dye is there, sir.
No, on the ureter.
Yes.
Is the ureter straight or some kink is there?
So some, sir, it's a peristaltic. Sir, it's looking normal, sir.
Light kink is there. It's usually normal. This is the 15-minute film.
Yes, sir. The dye is also now is coming to the left side also. With the peristaltic movement can be seen. No any hydroureter. No hydroureter is there, sir.
This is at 45 minutes.
So delay it's a delayed film, sir.
Post-wide film.
Post-wide.
So already we have discussed what are the things in IVP would like to see. So anything else you would like to see on this IVP? Before, suppose you only have IVP, you are planning your procedure. What are the things you would like to see?
Sir, RGU, sir.
मारबो शोरेर बच्चा साला
RGU.
लिखे ना हाँ एक्नॉलेजमेंट उससे लिखे
Hello.
Suman.
As though we have only availability of the IVP, sir, and the system is looking good. I will like to do the RGP during the procedure if I have planned for the PCNL, sir.
No, that is what Paul sir was telling that he would plan his punctures and everything, seeing the CT urogram. He'd see which is anterior, which is posterior, which is the calyx to go in. So could you gather that information from one IVP?
Sir, no, sir. So it is very difficult. Yes.
So there's CT, there's the first film, second film, or a few cuts. There's a sagittal section, and there's a reconstruction. So this is the film. Would you like to comment?
Sir, this is the selected non-contrast computed tomography film showing the partial staghorn calculus filling the left side of the pelvis and middle and lower.
Partial staghorn when you call it a complete staghorn?
Sir, partial if there is a component, one pelvis and the pelvis and one of the calyx is in two of the calyx is involved, sir. Then it's
sir, pelvis and one of the pelvis, one of the calyx is the partial, and more than two on pelvis is a complete stone.
Sir, if it is one is involved, that is a borderline, sir. And the partial, if it is two is involved, sir.
Any clearance from the expert?
Sorry, sir. Sir, it's a Roseweller classification, sir, which is saying the borderline is PCS and one of the calyx, and partial is PCS and two of the calyx, and staghorn if it is 80%, and the last is the gigantic, which is almost 100%, sir.
If you can clearly see the picture, this is the X-ray QB. There are three extensions of the stone, and all the three calyces are dilated compared to the opposite side. It's very minute calyces. So you can classify is that a complete staghorn. No, so quite small for a complete staghorn, but the criteria it's fulfilling. About this CT, you continue. Can you see a small separate stone?
Sir, yes, the cut is like that.
Cut is in single cut. We can't say it's different or it's isolated or it's the same.
If you see the X-ray film, there's one small stone in the lower pole. That is a separate.
Yes,
can you see?
Yes, sir.
Yeah. And this is the film which is showing a separate small stone. So this was what Dr. Pal was telling, that in CT he would like to know whether it's in anterior calyx or in posterior calyx. So this stone seems to be in anterior calyx. And with the dye in the system, he would plan his punctures accordingly. So this is the CT report. HU is 1000 to 1400 depending on the side of the stone. So now anything else would like to investigate, or you want to go for the management?
Sir, right now, sir,
I would like to treat first current urinary tract infection, which is as per a culture antibiotic. Patient is E. coli positive.
Already, sir, it's
E. coli positive.
positive, so we should do the urine culture again, sir, in this patient, sir, after antibiotics.
So how many days will you wait after treating the UTI? And how long will you wait? If the recurrent cultures are coming positive, will you proceed or will you wait?
Sir, as the staghorn is mostly infective pathology, sir. Sir, we will start the injectable antibiotics, sir. If there is no any symptoms, sir, so we can go for the injectable antibiotic, and then we can plan for the intervention, sir.
Is
No,
sterile
just a minute,
is sterile urine mandatory before proceeding to PCNL?
Sir, yes, sir. Sorry, sir.
Listen to me. What Nitesh wants to know is, like, if I would be you, what answer I would give is, sir, if it is, even if the culture is positive, I will start culture sensitive antibiotic, injectable antibiotic, provided, and 24 to 48 hours prior to the surgery, provided his counts are normal, there are no symptoms, no flying tenderness and no fever, I would proceed ahead with the definitive management. Rather than the answer you gave, I will start injectable antibiotic and then you stop. That is not the answer. What antibiotic you want to give?
Culture sensitive antibiotics.
That you have to say. You know it. It's not that you don't know it, but you just think over it. Otherwise, Nitesh would not ask you 5 questions for getting the same answer. Then you can move on. If you answer like that, the examiner knows that you know your subject. He will not waste time on these mere questions, MBBS or MS level questions.
Sure.
Okay.
Yes.
So you got your culture negative, luckily, or you have started on broad spectrum or the culture sensitive antibiotics. Patient is asymptomatic. Now you want to treat your patient. What are the treatment options you have, and what will you select for this patient?
Sir, I will go for the PCNL, sir, for this patient, sir.
PCNL, standard PCNL. See, nowadays things have changed. So you have to tell in slightly detail about your plan. Which PCNL you would like to go?
Sir, standard PCNL, sir.
Standard PCNL.
Yes, sir.
Yes. And earlier days were different. Now you have to tell whether you would like to go for prone or supine.
Sir, sir, sir,
whatever that is taught in your institute.
Sir, we
it's
are
not
generally
mandatory,
doing,
but you should add it to your answer.
Yes, sir.
Okay.
Yes.
What about the other things? Would you like to try ESWL in this patient?
No, sir. At the size of the stone is 3.2 centimeters, sir. So it's a very big stone, and there is a chances of remnant stone, as is it's a staghorn. Most probably it's an infective stone, so we need almost 100% clearance for this patient, sir. So I think so. The standard PCNL should be the.
Any role that ESWL can help you in your treatment process?
Yes, sir. If there is a sandwich method is saying, sir, if there is a remnant stone is there, so in that case, sir, after PCNL, we can go for the stented ESWL. So
there are two things. Whether the salvage ESWL can be there, and one more people were talking about is a sandwich procedure.
Yes, sir.
Okay.
Sir, before PCNL,
go for ESWL, then before, and then PCNL.
PCNL.
Yes.
So
what
just
about RIRS?
Just before RIRS, what are the definitions? How do you classify PCNL? What is standard and what is the others?
Sir, previously, sir, in the old days, 26 French dilatation is called standard, but nowadays it's more than 20 French dilatation is called standard PCNL, or the less than 20.
Sonu, Dr. Patidar, what he's saying is correct or what he's saying is incorrect? How do you classify PCNL? Because you use this word standard PCNL 5 times. So you should be knowing, because you only invited this question. By saying standard PCNL, you have only invited this question. If you have said, sir, I would do PCNL, and then the examiner would have asked you what PCNL, sir, I would have used a 24, 26 French implant. So the question would have been over. Now you said standard PCNL at least 3 times in your things. So what is Sonu? He says anything above 20 French is standard. Do you agree with that?
Yes, sir. More than 20 is
more than 20.
Yes.
Is it 20 or 22 French?
Sir, earlier
Sir,
it
more
was
than 20,
26,
22.
now 20.
20 or 22 French?
22
What
French.
is, how do you classify standard, mini, ultra mini, and micro perk? What is the definition of these PCNLs?
Sir, more than 20 is standard, less than 20 is mini, sir, and less than 12 is micro, and less than 5 is called micro, sir.
So next, Nitish wanted to ask you something. Observation, is that an option? Asi, I wanted to ask RARS was one by one. Okay.
Yeah.
RARS was asking.
So, would you like to go with RIRS in this method? And what are the cases you will go for RIRS?
Sir, the standard guidelines for the RIS, the stone size of 1.5 to 2 centimeters, sir. However, the more generally, it's if there is a more than 2 centimeter, the operation time will be increased, sir. And but if there is a we don't have the facility and only we have the RIS, we can go for the RIS.
Yes. What is the absolute contraindication of a PCNL?
PCNL, sir.
Sir, there is a active UTI, or there is an coagulopathy, or pregnancy also, and then associated malignant tumor.
Yes.
So, if you remember, patient is a cardiac patient. He is on blood thinners, dual antiplatelet agent. Suppose patient is on coagulopathy or there is an absolute contraindication of this patient, you can go for a multi-setting RIRS. That should be your answer if someone asks.
Yes.
Would you like to go for a pyelolithotomy in this case, or what are the what are the conditions or criteria or the situations where you would like to go for a pyelolithotomy?
So if we have condition where the chances of the complete clearance is not possible through the PCNL, and if we want and the patient is not giving consent, and there is a history of other associated things like large cyst or any malignancy. So in that case, we can go for the open pyelolithotomy also, sir.
If you see here, it's not written open or lap or anything. So it's just a pyelolithotomy. Open surgery, one should be knowing at every place. And if this kind of cases comes to your institute, if you are in an institute, you can request, if the patient agrees, you can request your seniors or your teachers to teach you the art of open pyelolithotomy, the art of extended pyelolithotomy. Because once you are out of your institute, you'll never ask a patient for these stones. So get it open. Where whenever there is a lack of armamentarium in your institute, sometimes scope gets damaged. Sometimes even some centers will not have that much scope, and some patients will insist you, no sir, I want to get it open, I want to get it open. In those cases, you can go for pyelolithotomy. And for experience base also, if there is a concomitant PUGO obstruction, so you can go for concomitant procedure of pyeloplasty and pyelolithotomy, whether it be open or lap. Nowadays, all robotic surgeons want to do everything with robotics. So, the last question, is observation an option here?
Sir, if the patient is moribund, sir, and we can't give the general anesthesia in this patient, sir, and the life expectancy is not good, sir, in that case, we can go for observation also, if the if the create norm is normal. So in that case,
I've got two questions from it.
Yes, sir.
One is that what are you going to do with the dual antiplatelets?
Dual antiplatelets, sir?
She's on dual antiplatelets.
Sir, nowadays, sir, there's no need of the stopping of the antiplatelets, sir. But previously it was saying that
cardiology consultation,
24 hours before a procedure, we should stop the antiplatelets.
You want to do a PCNL, you do not want to antiplatelets.
So dual antiplatelet should be stopped 5 to 7 days before after a cardiology consultation.
So basically, you have to stop and then bridge it. You are not talking about HOLEP. You are talking about the PCNL here. So you have to stop the dual antiplatelets 5 days back and bridge it, and then stop maybe icosapent 2 to 3 days prior to that one. So not that you do not stop. You are talking about HOLEP nowadays. That's a different story. But PCNL, open pyruvate, even RIRS, you have to stop that one. But obviously, the cardiac consultation, if they say you cannot stop it for even for 2 days, then you have to go for RIRS. That's the situation. The second question is that open pyruvate, when you said it is not done very often, but maybe for financial reason you have to do it. But given a choice, you have got both in hand. What is maybe the problem with the pyruvate, open pyruvate?
Sir, it's incision is larger, sir. There's a more patient will still.
No, I'm saying in this situation, in this sort of stone, the open pyruvate, it is not a simple small stone there.
Yes,
so,
sir. There's extension in the calyces, sir. There's a chances of leaving some part of the stone in the kidney, sir.
No, on the contrary, it is not actually. The dissection may be difficult because these xanthogranulomatosis reactions are more in sort of long-standing stagnant calculus. So it may not be always easy. If you can clear it with a PCNL, there is no reason why you shouldn't. If you are doing PCNL, if you are not an expert, that's a different story. But if you are doing PCNL, there are not many calyceal extensions where you are facing difficulties. This is a straightforward, relatively simple PCNL. But on the contrary, open pyruvate can cause problem of the XGP reaction, and that may sometimes cause a lot of problem.
Yes.
Okay. All right, Nitish.
I would like to comment from Dr. Ranveer. Dr. Ranveer, sir, would you like to comment?
Hello.
Yeah, Ranveer, sir, please.
Hello. Yes. Harpreet, I think it is a good discussion, but practical discussion should be there where Dr. Shivaju Vasu was telling the things. And I will again request in a diabetic patient, contrast should be avoided, IV contrast, long-standing diabetic, glomerular changes, GFR low, she will fall in trouble, in my opinion, it lasts for 30 or 35 years. So RGP and plain CT, DTP. So that should be the standard answer as far as, but also Sahab is having long experience. He has insisted on IVU. So don't get the students confused. So whatever the examiner likes, that is the answer. But for practical purposes, safety of the patient in the first line, I said, should be most important. So that's my thing, and everything is going on well. Nitesh has done well. So you can list all my comments right now.
Paul sir, any quick comment from your side? Paul sir?
Yeah, I don't agree that antiplatelet medicine can be stopped only for 1 or 2 days before, because the effect of medicine lasts till the life of the platelet, and which is about 7 to 10 days. Once you have given antiplatelet drugs, till that platelet dies away and the new platelets come in, till that time the effect will be there. So 7 to 10 days, particularly for PCNL, you should stop the antiplatelet medication. Regarding nomenclature, 7-8 years ago, there was a paper which had classified these confusion of PCNLs according to size, and they had mentioned about like the shirt sizes extra small, XS, then small S, mini PCNL, M, large PCNL, and extra large, and so on. But it was not accepted that there is a word consensus on PCNL, one publication which we have made. 57 consultants from all over the world, I am also part of that paper. We decided to which particular size should be the cutoff criteria for standard PCNL versus mini PCNL. So we pointed out that it should be 24 French should be the cutoff. Anything 24 and above should be standard, and anything below 24 can be considered mini PCNL. But still, this is not the part of the text universally accepted. These are only publications which may or may not be followed. So there is no definite criteria that this is the cutoff point for standard versus mini PCNL. Thank you very much.
Published literature, 22 French and below. That was a cutoff which I read in one of the papers was 22 French and below is mini and 22 French and above is standard PCNL. But I think, sir, it is high time that to remove this confusion, this is published and accepted like a consensus group. Because otherwise it becomes very confusing what you are doing.
24. But anyway, this is still point of discussion, not that it has been accepted universally.
Dr. Pal,
Yes,
Pal, I think what we are talking basically the same thing. We are using a 21 sheet. To use that one, 24 sheet is a dilatation amplifier is necessary. So that is a standard PCNL on that way.
Sure,
I will put in the group one publication which I had seen and following so about the definition. So one slide I'll just put in the group after the discussion. So Nitish, I thank you for this presentation on this. So what is the message which we have when you are having a diabetic patient? You have a large stone in the kidney. You have to be carefully evaluate the patient. You have to see the renal function, do urine routine, urine culture. As Rahul mentioned, that a culture sensitivity you have to see and start 48 hours before IV antibiotics and take accordingly. Every case is not the same. You have to see whether there's a lump, there's a pyonephrosis, there's a hydronephrosis. You have to customize the treatment. If needed, put a PCN and then start doing the case. So what I'm trying to, this is an exam. This session is basically for the exam going. You have to say एकदम क्लासिकल टीचिंग भैया पीसीएनएल करेंगे ज्यादा कुछ मत पूछो एग्जामिनर को पूछो सुपाइन करोगे प्रोन करोगे और उनको पूछने दो क्या करने वाले हो आप बोलो सर पीसीएनएल करेंगे क्या करेंगे स्टैंडर्ड पीसीएनएल करेंगे लार्ज स्टोन है डोंट ट्राई टू मेक फूल ऑफ योरसेल्फ डू व्हाटएवर यू आर डूइंग इन regular practice. That is very important. Don't see fancy things. Follow Campbell because this is important. We are here because every clinician has a different way of tackling the cases. When you become consultant, jo man mein aata karo, but exam, follow the book and whatever standard teaching is there, just follow that. So we'll move to next case. Nitish, you will present the next case and yes. Sandeep will be asking the questions and all. The next speaker, our students have they joined? Dr. Tehzeeb and Dr. Arif, are they there?
Yes, sir. I am Dr. Tehzeeb, sir.
Okay.
Yes, sir.
Arif, yeah, both of us there. So Nitish will present the slides and Sandeep will be questioning and the third case will be taken by Rahul. So that is the way forward. So over to Nitish to start the second case. Second case is on, it's a symptomatic right upper ureteric stone at L2, L3, 7 mm stone. How to move forward. And Tehzeeb and Arif will take over the case and Sandeep will be narrating the session. Thank you.
Dr. Tehzeeb and Dr. Arif, are you ready?
Yes, sir.
Okay. So first, see in this slide, two words are written, loin and groin. So can any one of you describe the boundaries of loin and groin? Because the moment this word will be there, no, some examiners will want to ask the definition of loin and groin. So just a basic discussion I wanted. Do you know what is loin, groin, and flank? These are three things which you should know as a resident, and in exam, the examiner might ask you. Anyone? You can try. Dr. Tehzeeb?
Sir, loin is the area between the 12th rib, paraspinal muscles, and so the posterior axillary line.
Okay.
And sir, groin is the inguinal area, sir. Where the as per the the lower abdomen myopectoral orifice of Fruscia, as we had studied for the hernia, lower abdomen
So it is the medial most aspect.
So,
and flank is a bigger area.
Yes.
So you should know the boundaries.
Groin, it is still the pubic tubercle.
Yes, yes. And flank, which is a bigger area, flank or a loin?
The flank is the bigger area.
Yes, flank is bigger. Fine. So we'll proceed to the next slide if Dr. Nitesh is there. So acute management. So he's asking how you will proceed. Like, first of all, you will give the symptomatic relief to the patient. Next, Dr. Nitesh. So what are you suspecting at this moment? I mean, what are the differentials in your mind with this history at this point of time? 1, 2, 3, what are the probable causes of this pain you may think of? Please go to the first slide, Dr. Nitesh. So just this history, age of the patient, the site of pain, the nature of pain associated with vomiting. What are the differentials you would like to think of? Please answer, otherwise we won't be able to proceed.
Sir, my first differential diagnosis is ureteric stone.
Means ureteric colic, right? Okay.
Yes, ureteric colic.
Okay. Second?
Second diagnosis is UTI involving the upper tract.
UTI. You mean which particular UTI? UTI is a very broad definition. So what?
Pyelonephritis.
Acute pyelonephritis. Okay.
Let's keep on moving. Keep on answering, guys. नहीं तो हिस्ट्री में रह जाओगे, डिस्कशन नहीं हो पाएगा.
Okay. So these two basic differentials. Okay. So Nitesh, can we proceed with what next we have after pain management? So sir is asking which is the choice of analgesic you would like to give to this patient.
Sir, NSAIDs is the drug of choice for acute pain management in ureteric colic, such as diclofenac or injection Voveran.
If it's not relieving, then
what if the patient is a CKD, he has underlying kidney problem, and you give a Voveran, and is there any other better drug you can give which is safe, and before getting the
yes, sir, alternatively we can
use that drug?
Alternatively, we can give paracetamol added with dotaverine injection, sir.
Or better combination which is easily available. Can you give simple Tramazac injection and a Buscopan injection? IV Buscopan and intramuscular Tramazac, which is both safe for the kidney?
Yes, sir, we can give, sir. But tramadol has side effects of
medical legal issues, because without creatinine, until the patient is your old patient, you know about the history of the patient, you know that these kidney functions are perfectly normal. You should not jump to Voveran directly. You can give Tramazac, give Buscopan, you buy some time, 1 to 2 hours, by the time creatinine comes, and then you can do whatever you want to do.
Yes, sir.
Okay.
Okay. So once pain is relieved, what would you like to do? Next slide, please. So now investigation. So Dr. Arif.
Sir, for investigation, first I will do an USG whole abdomen, urine REMACS, and basic blood investigations such as CBC, urea creatinine, CBC, and fasting or random blood glucose.
Random blood glucose. Okay. Do we have these investigations, Dr. Nitesh?
No, so investigations It was almost normal. I didn't put up the slide. Everything falls within the normal. Urinary, there 4 to 5 RBCs per high power field and 5 to 6 per cells per high power field. Creatinine is 0.8.
And to play spoil sport, I'll say ultrasound is normal. And to play spoil sport, I'll say ultrasound was normal.
Yes. So USG is normal.
Is
as Sir is saying.
We could have done something which would have given diagnosis just upfront there. What is the sensitivity of ultrasound in acute urinary colic? Sensitivity and specificity. Yeah, ultrasound can be normal, no issues. It is a routine.
Sir, sensitivity is around 57 to 81%, sir, and specificity specificities are around 80%, sir.
No, you are wrong. And it is an investigation which is operator dependent. It is not a very specific because you are not doing it open. So what investigation as a candidate, what investigation would you have done to reach to your diagnosis and move on? One investigation and you would have moved on.
We can do a non-contrast CT scan.
Is it a better alternative? Pal sir, what would you as an examiner would have accepted the investigation from a candidate to clear their confusion in present era? Pal sir is there?
If there is any confusion, NCCT, non-contrast CT scan will be better.
So, sir, my request is if a candidate upfront answers this as an investigation, as the examiner is asking what investigation, and the candidate says, sir, I want to do an NCCT on a KUB of a patient. So, I think one should not get, one should accept it as a norm as of now, rather than an exception. What is your opinion about that, sir?
Yes, certainly, because nowadays NCCT is available almost everywhere, and even in emergencies it is being done routinely for all suspected ureteric colic. If you want to be doubly sure, just get a urine routine examination, and if shows RBCs, WBCs, then you are fully justified to do an NCCT in such case.
Because ultrasound, if you are doing yourself, is a different thing altogether. Otherwise, patient has to go stand in a queue, get an ultrasound done, which is very non-specific, comes back, the sonologist says normal ultrasound. So again, you are back to square one, and then you send the patient for a CT. So it is better to get a urine routine for a specific patient, urine routine, and a non-NCCT KUB. So that will clinch your diagnosis.
Rahul,
Sir, in examination, sir, we can just exclude the USG from the investigation protocol.
Yeah, for acute colic, if the presentation is such, in case of acute colic, you can safely exclude USG because there is no information which CT will not give you of the USG. But there is multiple things which CT will give you, which is not available on USG. So you're well within your rights, justified to say that I want to get an NCCT KUB, and you can justify by quoting this 90+% specificity and sensitivity.
Yes.
You are justified by saying that it is not operator dependent. If somebody gets the plates to me, even I can read and the things, and I can tell the patient you're having a stone disease or something.
I've got a point to make. One is that actually ultrasound is a part of the extension of the clinical examination now. So that cannot be ruled out that way. And 27-year-old girl, a pregnancy, you have to see the gestational, pregnancy, exclude pregnancy, where the CT scan, the analgesics, and a lot of things will matter. So you never know. So you do that test at this stage.
Rahul, what I feel for the students who are going exam, we're going to clear masses. I agree with your point, but I think for the students, ultrasound, as Dr. Sirogi Bada has mentioned, it's a part of a clinical extension. It will at least, if it's good colic, it can give you a hydronephrosis, it cannot give you a hydronephrosis. So ultrasound next QB can be the first line of treatment, and after that, let's not confuse there. And that is what we always do in our practice. Even किसी patient को CT कराने बोलता सीधा CT करा रहे, they want to earn money.
Yes.
Different issues and different scenario it will go. So
yeah, I'll tell you, Harpreet, because if you go to any,
should not confuse them.
For example,
ultrasound and QB, let be the first line of treatment. That's what we have been also taught, and we be following it. I took
Dr. Pal's opinion that in present day, if a candidate, because I was an examiner at Just Look, and I'll just tell you upfront, And when similar sort of a case, and only I was the one who said ultrasound is justified, but everybody said no. In today's era, you want to do the CT. That is why I wanted Pal's final opinion as an examiner. We should be more considerate to the what is present scenarios happening. And if you are gone to a good center, if the patient comes to a good center, CT is freely available. If you are doing your ultrasounds yourself, then it is no harm. You can put a probe and see it then and there. But if you have to send the patient for further, I think it is better to send the patient. If you say it is justified, it will not. Nobody will crucify you for that.
I hope so. It varies examiner. They should not be biased about it, but it's a very confusing. I think. So what message I want to give students: whatever you say, it will not be held against. If you want to go with ultrasound and X-ray KUB is fine, and if you say non-contrast because they say in acute abdomen non-contrast CT scan is good. We are doing multiple choice question from errors down. But whatever you feel, whatever is available, so do that. We are in a medical college setup, so I feel ultrasound KUB is also a good answer.
But here I would like to say one thing, sir, that here we are in a clinical discussion. And right now we are not even sure whether it's a ureteric colic. So as residents, right now, as Shivaji sir said, that the diagnosis is open. So a USG should definitely be the answer at this stage. And even non-urological differential should be considered at this stage. This is what I feel.
That's what I told, that ultrasound KUB is a good answer. Let's move forward.
Yes. So, Dr. Nitesh, you said the USG was normal, right?
Yes. USG is a mild right hydronephrosis, nothing else.
Fine. So we have the scenario right now that USG has showed right mild hydroureteronephrosis and urine RBC shows 5 to 6 per Haifa field. So what would be your next protocol to further confirm the diagnosis?
Sir, for further confirmation of diagnosis, now I will go for NCCT KUB.
Okay, Dr. Nitesh.
Why not contrast CT?
Sir, for diagnosis part only, NCCT will be sufficient, and contrast scan is obviously indicated if there is any plan for intervention. We don't yet know whether what is the renal function, functional status at this point.
So why didn't you ask for a creatinine? Why didn't you ask for a creatinine?
You could ask for the creatinine now.
Yes, sir. If the urea creatinine report is available, then.
But you did not ask. As an exam, in the exam, your next investigation should be a urea creatinine. You should ask for the report of urea creatinine. And exposing a patient 2 times to CT scan makes no sense. If the creatinine is normal, you can do upfront CCT.
Correct. You could ask for uric acid also at this point of time. There's no harm asking that.
Okay. So creatinine was how much, Dr. Nitesh?
0.8, sir.
So creatinine is normal. Would you like to correct your imaging?
Yes, sir. Now, as the urea creatinine is normal, then I will go for contrast enhanced CT scans.
Okay. Dr. Nitesh?
Yeah, but so this is the recommendations from EAU. What they say that using ultrasound should be a primary diagnostic imaging tool, and they say that use non-contrast enhanced CT to confirm stone diagnosis in a patient with acute flank pain following initial ultrasound assessment. So if you say ultrasound assessment should be the initial thing, it's nothing wrong. But for the practical scenarios, if it is not available at your center, then sending a patient for an ultrasound and then again to CT creates some kind of problem. But we are talking about all the ideal scenarios that everything is available at your disposal. If you come to get your ultrasound, then you send him for CT. So, anything else would you like to be cautious in children's and pregnant women? Would your plan of management or investigations change?
Sir, in case of pregnancy, once again, ultrasound is the first recommended investigation of choice. If ultrasound fails to give an unequivocal diagnosis, then MRI would be the second line investigation of choice.
Can you do a CT scan in women, pregnant women?
Sir, in pregnancy, the conventional CT scan is absolutely contraindicated. Only low dose protocol or limited dose CT scan is recommended as the last line option for diagnosis of urolithiasis in pregnancy.
And in children?
In children, we can go for an IVP.
Again, you should say at least.
It's a ureteric colic. You are not hardly see hydronephrosis and IVP. There's a lot of gas. You cannot prepare the children. You're still not able to see it. So if it is needed,
NCCT, sir.
Yeah. So
If you're suspecting it's a ureteric colic, then
people will try to confuse you. So don't confuse, boss. Get confused. Bachcha to imagine to diagnose it. So don't get confused by all these scenarios. That's not the idea of this.
About the use of contrast in children. Would you be happy to perform a contrast study in children with the same ease, or would like to abstain or refrain from it?
So you can hydrate the children and can perform the CT scan. You can do a low dose contrast CT. Low dose contrast CTs are also available, and now where the safe contrasts are also available. So if you want a functional study, say functional study, because before CT was not there, we are doing IVP in children day in and day out. So it's not wrong. Why are you so confused? How you have managed the children in your department? So you're looking very confused. You're thinking that exam scenario is different and your day-to-day practice different. No, it's the same. Arif and Tezi, why are you?
Yes, sir.
Keep on going the way you're doing in your department.
These are the investigations that was asked for.
You are getting confused. Why are you getting confused?
Sir. Sandeep, sir.
Fine. So we have all the three imagings in front of us, and the final diagnosis is a right upper ureteric calculus of 7 millimeters with hydroureteronephrosis as evident on USG. So how would you now like to proceed in this case, Dr. Arif? What are the options you have right now? The patient will tell you that, sir, my diagnosis is this. Now tell me how to go about it. So what options will run in your mind?
First, if the patient is really from symptom on emergency management, then I will discuss the prospect of different treatment options with the patient.
What
right
options?
Now, sir, we have option medical expansion therapy, ESWL.
Did you ask
URS,
for the Hounsfield unit of the stone on CT scan? Did you ask us how much is the HU of the stone?
No, sir. During sir, treatment planning, all these are important.
So you are now planning, right?
Yes, sir.
Okay. Would you like to know or not? In this
yes,
case?
Sir.
Okay.
For the SWL, the Hounsfield unit of the stone, size of the stone, whether there is any distal obstruction distal to the stone, sir, whether how many calyxes and total stone burden is important, sir, for ESWL. So you have to know about all these informations.
No. In addition to this, what all is more important? One is Hounsfield unit. Second is just single point questions. One is Hounsfield unit. Second is
stone size.
Third is
stone location.
Very good. This stone is located where?
Sir, if the stone, this stone is located at, sir, upper ureter, sir.
Upper ureter.
Right upper ureter at the level of L5, L2, L3, sir.
And fourth, what is, I say at PUJ, fourth, what is more important, which is not been shown here in the CT, neither in the CT nor in the KUB. The most important part before you give ESWL.
If the stone is impacted or not, we have to test. Because
skin to stone distance. Skin to stone distance.
That is different. That is in the last. Zyada important kya hai? What you are not able to see neither in ultrasound, nor in KUB, nor in NCCT. Will you give ESWL to a non-functioning kidney unit? Will you give ESWL to a poorly functioning kidney unit? Would you give ESWL to a acutely obstructed kidney unit? So all this information will be given from what? From the functional. Is there a contrast study here?
Dr. Nitesh, do we have a contrast?
No, sir, contrast study was not there.
So this from a candidate point of view, even they should think about this thing before jumping to VSW or anything. You should have the functional study that will give you the anatomy. It is a duplex system or a single system, you don't know. It is functioning unit, you don't know. If it is a compromised system, you don't know. It is impacted, like somebody said, impacted stone, you don't know. So because ESWL result will depend on all these factors, no?
Yes.
Yes, sir. Yes.
Achha, medical expulsive you said about. So one option is medical expulsive therapy. What is the literature support for medical expulsive therapy in an upper ureteric stone? How does medical expulsive therapy act?
Sir, adequate hydration is the cornerstone of medical expulsion therapy, added with muscle, smooth muscle relaxation. And sir,
smooth muscle relaxation. What smooth muscle relaxation for upper?
With alpha adrenergic blockers, sir, such as tamsulosin.
How do alpha adrenergic blockers act and relax the smooth muscle? What smooth muscles do they relax? What is the principle of MET?
Regarding upper ureteric stone, there is very minimal benefit with alpha on adrenergic blocker because the receptors are located.
Wait, that is my point to you. When Dr. Sandeep asked you what are the options, the first option you gave him was, sir, I would like to do MET. Am I correct, Dr. Sandeep?
Yes.
This boy said. So you cannot, you see, that is what I'm saying. When you sue a seat, you think about it, what you are talking. If you would have said ESWL first, you would have agreed upon that. If you would have said, sir, I would not like to do a functional evaluation. See, examiner has not given you, but that does not mean that you don't ask it. If we say it is not available, then onus lies on us. But if you have not asked for it, that negative marking goes to you that you have not thought about it, that you require a functional evaluation to treat this stone. You understand my point, what I'm saying?
And one more thing I would like to say here, functional status of the opposite kidney is also equally important.
Equally important. It may be a single kidney, you know.
Yes,
MET is the answer for upper ureteric stone only if examiner is pestering you. No, what else can you do? What else can you do? Then you will say, and you will never say alpha adrenergic blocker for upper ureteric stone. One thing you can use for that is, and that is what can you use? What can you use? You can use a low dose steroid. If there is edema, the edema may subside, or you can use a simple muscle relaxant like anti-inflammatories that you can, but you cannot use the alpha, you cannot say I'll use alpha adrenergic blocker. So what that reflects is you don't know the basic principle of MET. Okay, move on. Dr. Sandeep, you can ask anything. So it was a normal functioning kidney, but it is an impacted stone. What is your choice of treatment in this stone? What is the definition of impacted stone first? Somebody said impacted stone. Which candidate said that?
Yes, sir.
What is the definition of impacted stone? What is the definition in Campbell of impacted stone? Tehzeeb. Bataएं.
The impacted stone is one if on a functional study the contrast is not seen distal to the stone, And in an endourological procedure in URS, we cannot pass the guide wire beyond the stone.
Another thing in relation to duration.
That is two.
Third.
In relation to duration, anything is there?
Sir, no change in location. Over.
Yes, yes. Correct. You are correct. What is that?
Sir, over 3 months, sir.
3 months? 3 months is a long time, man.
Sir, 2 weeks, sir. So we give MET for 2 weeks. If it does not for low nutrition, then
no. Don't bring MET here. Again, you are taking a book for yourself. So
See, simple question. Impacted stone in terms of duration. आप MET भूल जाइए अभी.
So definition 1 you said is no contrast below, no guide wire above. Third is the duration of stone is the static. So suppose patient has come to you 1 week.
Yes, sir.
Did it KUB 7 mm, kidney is functioning well.
Yes, sir.
कोई बात नहीं, आप 2 हफ्ते के बाद दोबारा आ जाओ. Patient says I don't want a surgery. They come after 2 weeks or 3 weeks. Repeat his KUB and the stone is there only. So then again it is a impacted stone. What is the fourth one?
Yes, sir.
Fourth one. चौथा कौन सा होता है? तीन हो गए ना, अभी 3 सबको पता चल गया, चौथा क्या है?
Yes, sir.
When you are putting a RGP and the contrast is not going above.
Yes, sir.
Contrast दो वे में दे सकते हैं ना?
Antigrade or
yes, sir. Yes, sir. Yes, sir.
Always, whenever it is very important when you say something, you have to know what you are saying in the exam. It's very simple, basic, but you should know these 4 points when you call a stone as an impacted stone. Okay. So now for this stone, what are the treatment options?
चलिए डॉक्टर तहजीब 1 2 3 4 फटाक से बोलिए. ट्रीटमेंट ऑप्शंस. सर हैज आस्क्ड ट्रीटमेंट ऑप्शंस in order of priority.
What you would do in the serial of 1 2 3 4. Number 1 is, it's not a difficult question.
पहला ऑप्शन क्या?
Like
what is the first option?
The uretero, sir, I'd like to do URS and use laser energy source preferably.
Okay, so first is laser URS. Second option?
Laser URS.
Second option, first.
The pneumatic, we can use pneumatic.
Boss URS हो गया. Next.
Okay.
Second is?
So we can do a, so ESWL is not, we would not prefer here. If
we'll ask you. ESWL is second?
Second treatment option of your choice will be ESWL, right?
Okay.
So is it about impacted stone or just
in this case?
This case, Baba, सामने है आपको. Impacted ही है ये. Impacted समझ लो. Consider an impacted stone. Second is ESWL. Third is?
So we can do a mini PCNL and approach from above.
Mini PCNL. Okay. Third PCNL हो गया, बराबर है. चौथा?
Okay.
See, the patient, you have to explain all the patients before you put the patient on table.
Stone, 7 mm stone, there is no infection, counts normal, creatinine normal. I don't want to do anything.
Yes,
you can say
expectant management. Expectant management.
Exactly. Correct. So now you first option, Tehzeeb, you said, I want to do URS with laser lithotripsy. Am I correct? This is what you said?
Yes, sir.
What laser
yes,
settings you use for this thing? What laser settings you want to use for this thing? Which laser you want to use?
I'd like to.
Which laser you want to use?
Laser, sir.
Holmium laser. Okay. What setting you use? Yesterday, Dr. Harpreet took a class. What laser setting you use for a ureteric stone? And why?
Sir, I'd like to do in dusting mode 0.4 and 20 for.
So that is what wattage? That is what wattage it goes to?
Sorry, sir.
Total output goes to how much? 0.4 and 20?
So 8. 8.
What laser spins you want to use? 200 microns, 365, 400?
365, sir. We use 365 in our institute. So we'd like to keep the power. We'd like to keep the power below 10 or 12, preferably in the ureter.
When would you not like to use laser? You You have laser, but you say, no, don't give me laser, give me lithoclast.
If there is impacted stone gross edema where the use of laser there would be increased risk of ureter wall injury. Then in those cases,
short,
I would like.
If you cannot see the stone,
yes, sir, gross edema.
If you can't see, don't use it.
Yes, sir.
Correct. So, but AUA guidelines, what are the now AUA guidelines? What do the guidelines say? What should be the preferred first line of treatment for such stones? For a 7 mm,
there is no difference in in the efficacy for both ESWL and URSL for upper ureteric stone less than 10 mm.
No. But what they recommend as per serial wise, ESWL is the first choice of treatment.
Yes, sir.
Yeah.
Less than 10 mm, as you mentioned, is the first line of treatment, and so you have to answer that way.
So one option is written here, DJ and RIRS later. Are you convinced with this option?
Yeah, we can do DJ.
So what he means to say is just put a DJ, come out. Again later, maybe after a few weeks, go for RIRS.
I would like to, so personally, I would like to complete the treatment at this stage. But if the stone migrates to the kidney, then I would like to put in a DJ stent and come back for RIRS later.
Suppose you enter the scope and you see there is a purulent urine coming out. What will you do?
I'd like to abandon and give a stent and come back, sir.
Sajeev, you are doing URS, you're doing it very nicely. So what measures you will take so that the stone does not migrate to the kidney?
See here, as sir is asking, see, very important in upper ureteric stone, your counseling of the patient. What all can happen during the procedure that we have not discussed. So indirectly what sir is asking, what is the most common problem in upper ureteric stone? Up migration, right? So how will you, yes, that's what, up migration. So how will you prevent it? What steps you will take to prevent it?
So after reaching to the level of the stone, we would like to keep the head end of the patient up. We can use if a guide wire can be passed beyond the stone, we can use a stone cone, which will prevent migration of the stone.
Any role of diuretic?
So diuretics can be used, but there's one problem with it, that it increases the ureteric peristalsis. So it has a advantage and disadvantage both.
So you don't have a stone cone, or the stone is so impacted that you're not able to pass a stone cone. So
we cannot hear you.
Any other method? Will you modify your any other thing which you can do to prevent the stone formation? Anything related to? I'm giving you hints, some position.
Sir, continuous suction, sir. Adding suction catheter.
What suction catheter?
Suction catheter. Okay. Suction is a new thing, but
I would not prefer suction in the ureter, even if you use very low pressure, but we would avoid suction in the ureter. We can keep on aspirating with a syringe, but not more than that, sir.
You can something up so that you can make the kidney level little high. You can put some water or something there, or you can tilt the position to the opposite side so that stone doesn't move. These all are the things which we practice in now with the laser available, laser has got less retropulsal pulsions in the pneumatic, and you can use small strokes of pneumatic. Don't use spontaneous strokes. And the moment you break stones, you keep on removing. Either you can use forceps with the rigid ureteroscope, or you can use it at the Sandeep mentioned using diuretic. They can keep on passing. You have to do a little frequent up and down. These are the things which you use to practice when you want to avoid the second procedure. Otherwise, now with the flexible available, you can just, if the small fragment goes into the upper kidney, you can easily go and take that stone fragment out. That's one advantage we had now in the practice. I just want to ask panelists, in earlier times we used to have dilate the ureters because I think we had the scopes available with 8 French and 8 to 9.5. So I would like to listen from Dr. Shivajida also, Dr. Pal is also there. So are you anybody dilating the ureters now? Are we using any dilators now? It's just not for the upper ureters, so I'm just talking in general. Are anybody dilating the ureters? Any settings?
Well, surely there are people dilating. I do not. If there's a doubt, I'll put a stent there. And now there's a 4 French ureteroscope available. So there is no reason why we wouldn't be able to pass the ureteroscope up. The dilatation thing with the Teflon or by the balloon dilators is still in position, but more people are showing to the putting a stent and come later on within 7-10 days and do it is a much safer. Number one. Number two, I would take this opportunity to tell the boys, Amit, that to summarize what Rahul was asking about this impaction. What is impacted stone definition? So whatever you have said, fine. But you add it, if you are doing well in the exam, you have to add the level of your diagnosis of impacted stone after your procedure. While you're doing your ureteroscopy, you see that edema. While you, after the successful disintegration, you find the wall, the stone things are stuck to the wall. That is impacted stone. So these two are post-op diagnosis. So you branded at the discharge that this was an impacted, grossly impacted stone. Just add to those apart from the definition. One was the pre-op and two are post-op. So answer to your question, Harpreet, I don't dilate.
Also,
unless I'm really stressed that you cannot even pass a guide wire up. That is the thing.
Right.
If the stone bulk is 10 millimeter and more in the ureter, I try to use a 7.5 French ureteroscope. And when I am using 7.5, I would like to dilate before that. Any scope less than 6 French doesn't need a dilatation. So I will use only when this ureteroscope, larger ureteroscope I am using, then I will do the dilatation.
Yeah, I also do the same. If I'm using a larger ureteroscope, I do dilate. If it is possible, don't push my dilators. If my dilator goes easily, so I try to dilate up till stone. Not only dilate VUJ. So what happens with the larger scope, the fluid egress very quickly, and you are able to do it very fastly. But now with the 6 French scope, yes, dilatation has almost gone down. Rahul, do you have any other views than what we discussed? Sandeep? I think
no, sir. Maybe. I think this is okay, sir.
Right.
Secondly, as Dr. Harpreet was asking about the precautions that it should not go retropulsion, I will open the tap of ureteroscope, that fluid irrigation, to the minimum so that just we see step by step and move ahead. Sometimes a stone which has come recently into the ureter has not even got impacted. And right from VUJ, if you open the full tap without any instrument in the working channel, the passage of the fluid may be so fast that the stone will go back. Right when you are at VUJ, the stone will go back into the kidney. So just open this tip very slowly, or you can pass a 4 French ureteric catheter so that working channel gets narrowed. And then with little bit of saline injection through the ureteric catheter with controlled irrigation, you can open up the ureter and go ahead slowly, so that you don't push the stone back. These are the precautions I will take.
Yeah. So one Paul sir has told that remind me that when we are doing in this upper ureteric stone, one technique he has mentioned. Other, I just want to add to one more technique which we do, that we keep see you have 2 channels. From one channel of ureteroscope, the fluid is coming in. and keep the other channel also open little so that the pressure of fluid is always low. You barely see it. So that way, that's what you are also doing that pulses so that the fluid pressure is always low and so that it doesn't migrate with the fluid to the kidney. So that to avoid one procedure, and because adding PCNL adds to the cost when you plan for a URS. So, Shivaji, can you sum up this case for us? The take-home message for the boys, what?
Yes.
For a ureteric stone.
Right. This is not this one. This is the upper ureteric stone. This is showing a lower. But we are talking about the upper ureteric stone, and acute colic. We said that we will do the talked about the analgesics and ultrasound is the first diagnosis, and then if there is a doubt, you have to go for a CT scan, CT urogram, if you can possibly do that one. If you haven't got it, at least a non-contrast CT will show you. This X ultrasound which was shown, you couldn't see the stone. That's because the whole thing was the shadow of the L2 vertebral transverse process was blocking the ureteric visualization. So after you have diagnosed, what you have discussed, that we will go for the options, and obviously URS tips was the first choice. And while doing it, if you cannot get a 7 French ureteroscope up, then you have to do a ureteric dilatation by a Teflon or a balloon dilator. But if you can have a 4 French ureteroscope accessible, then you can put a guide wire by the side of the stone. That helps you, and that's a safety procedure. The ESWL is not the primary choice here. Basically, the expansion chamber of the upper ureter is not that much. Yes, the good ESWL needs an expansion chamber while the fragment will break there. So the dilatation was much more than that. Then not only ESWL, you could have put a PCN up if you couldn't put a guide wire from below. So, and then later stage you can do an integrate. But here, also we discussed that how do you prevent migration? Migration is, as I said, that we discussed that outflow of the cap. You open it up so that the irrigation is not very forced, and with the force of irrigation, the non-impacted stone will go back. Impacted stone doesn't go back. Impacted fragments go back. So there, you start with a very low laser, a 0.2, and then start from the below, and then gradually go up. That's the point. If there is a migration and there is an infected urine, you put a DJ and come out and do it later on. If there's a recovery, you can do a PSWL, you can do 0.7 millimeter, and you can also go and do the RIRS there. And so these are the topics we discussed. I think this is the picture which is showing an edema below the impacted stone. Then you know the impacted stone, and it is not safe to use a laser here. And really speaking, this sort of situation, lithoclast sometimes helps in sounding the stone. You can actually sound the stone and put a one small burst of lithoclast, not continuous. Then you find the stone, and then you go ahead with the laser. So that's, I think, we have got to say.
Thank you, sir.
Rahul?
Thank you, sir. Absolutely, you have summed it very nicely about the migration, about the approach to the stone, about different modalities. I saw Dr. Ranveer comment also that you should have some fluid around the stone to ESWL to have a good result, because fully impacted, you don't see any window. So he also mentioned that same. And Dr. Pal also has given us some ideas about how to approach this stones. We had discussion about impaction. So I think we did well on this case. Sandeep, any final word from you on this?
No, sir. The only thing I will tell is that we should not underestimate even URSL. We may think it's a very simple procedure, but
if you ask me, my personal view, Sandeep, even in practice, and I think all singers will also agree that upper ureteric stones now we are seeing more and more in practice. and that is the most dangerous stone to tackle with, because you might have to do URS, you might have to do RARS, you might have to do PCNL in one procedure, and that is where you are doing impaction stone. Chances of avulsion is very high. As Shivaji Da was saying, that use finer scopes, because when you try to use a very large caliber ureteroscope, you might get very high chance of avulsion, because it will be gripping. Because see, a stone has fixed the ureter to one thing, so I have to be very, very careful. Upper ureter is a very, very dangerous stone. I think in the last case we will again come to this avulsion, where we'll discuss all the things. So upper aortic, in my book, is the one where surgeon has to be, urologist has to be 100% alert. If especially you're doing it URS, though if you're doing this with URS.
And one more thing, sir, I think in upper ureteric stones, the anesthesia should be general anesthesia rather than spinal.
Perfect.
I think this is one tip.
Perfect. And it has to be controlled. Sometimes you have to anesthetize the whole breath. Otherwise, the movement, you will break your and you will avulse the ureter. So that is a very important point Sandeep has brought up. Yes.
Correct.
Thank you, sir.
Thank you, Sandeep, Nitesh, and Arif and Kazir. I hope that this must be a learning experience for both of you, and I'm sure this is going to
Thank you.
Can we'll move to third case, Rahul?
Yeah, I'm here.
You will present, or Nitish will present?
Let Nitish present. Let Nitish present. We'll ask questions. Because this
Nitish, yeah, exactly. When he has made it, he knows. So Nitish, go ahead with the third case.
There's a patient, 26 years old male, presents to us with...
Let me announce. The third case, we are discussing bilateral 1.5 to 2 centimeter stone and a recurrent stone formation in a young man. We have a two scenario. We have one is bilateral stone. So what I want to discuss is, what is the approach in a bilateral renal stone of 1.5 to 2 centimeter? This is what it should come out in our discussion. How can we approach this bilateral stone? And second, if it is a recurrent stone former, so what precaution should we take? So these two scenarios we should keep. We should not repeat what we have already done. And here Vaibhav is the Vaibhav is taking this case. Is Vaibhav around? Hello, Vaibhav, are you there?
Teachers are around. The student has lost.
वैभव कल तो अच्छा आंसर कर रहा था. कल तो था.
He is probably tired after yesterday.
He's logged in but muted.
Not the firing yesterday.
So who is going to take this?
We have another Vaibhav online. I think maybe we can tell him.
Okay, sir.
Well,
so
who's taking different Vaibhavs? No. The same.
No, we have to know who is taking this case. Is Vaibhav is there? Anybody wants to take this case?
Yes, sir. Myself, Dr. Zayed, MCH resident.
Good.
Dr. Zayed is there.
Okay, Jayed, you're also listed for the last case, right? Go ahead. We'll see in the last case who will take. Jayed will take the cases. Nitish and Rahul, you can start.
Yeah.
There is a 26 years old male came with this X-ray KUB at your clinic. It has mentioned around 16 into 9 mm calculus in right kidney, 19 into 10 mm calculus in left kidney, and he has a last USG of 2 years back that was showing a 7 mm calculus in right kidney, lower pole, and 8 mm calculus in left kidney, mid pole. He also has a big scar and a history of right pylorothotomy at 14 years of age, left PCNL at 20 years of age. He has multiple spontaneous stone passages history, no other comorbidities, and he works as a cook for a restaurant.
Okay, Zayed, my question to you is that you are a very good surgeon and this patient comes to you and he is asking for options of treatment and you explain that you want to do a PCNL or RARS. You have done that, stone is cleared. Now the patient is coming to you with bilateral stent in place. His both stones are out. He's very happy with your surgical skills. Now he has a lot of faith in you. because you have done both the stones in one sitting, bilateral simultaneous PCNL. So he says, you are the best because you have saved my money and everything. Now, Doctor Saab, why am I forming recurrent stones? How will you approach that aspect of the patient?
I would like to do a stone analysis of this patient.
Stone analysis 1, with what aim?
And then,
so what do you feel this stone looks like? To me, this looks like it's a calcium oxalate monohydrate around 70% and dihydrate around. This is my clinical experience says it looks like a monohydrate stone, 70 or 80%, and 25, 20, 30% is dihydrate stone. So what do you do now?
And metabolic workup of the patient, sir.
Yeah. What do you mean by the metabolic workup of the patient, and in what patients it is indicated?
Metabolic evaluation, the pathophysiology of a stone. That pathophysiology of a stone lies in the metabolism of different minerals in a particular patient or in a particular case, and this metabolic abnormality give rise to stone formation. So this is especially indicated in bilateral anal stones, indicated in recurrent stone formers, in young patients, or in patients who are having some anatomic abnormality of the kidney. So in these patients, metabolic evaluation is needed. Metabolic evaluation includes analysis of. You are not audible, sir. You are not audible, sir.
In anatomic abnormality, I would take an exception to that. You have to keep that in the last. Anatomic abnormality may be obstruction, then it can lead to stone formation. So they are secondary stones, not primary stones. So the anatomic abnormality you cannot put here. So I would initially we're talking absolutely fine. Anatomic abnormality should not come up front. It has to be last, or even if you don't mention it, we don't we agree with that. So now, recurrent stone, young, multiple, bilateral, recurrent stones. Other than that, can you add
family history of stone formation, sir?
Okay, 5. Then one more. Pediatric age group?
Pediatric, yes, sir. Young patients and pediatric age group, sir.
Young is different, Zaid. Young is different and pediatric is different.
Yes, sir.
So you have to mention pediatric age group. So this is the high stone former as he has mentioned, and you have also mentioned. So this is different. Early onset of stone, children or teenagers, familial stone formation, uric acid or urate stones, infection stones. Infection stones is fine, solitary kidney stones. And in addition to that, anyways, in pregnancy also, if you are forming stones, then again you evaluate these patients further on to look for any metabolic abnormalities. So how do you approach these patients? What do you mean by metabolic evaluation?
Metabolic evaluation includes blood analysis as well as urine analysis. In blood analysis, sir, we have to check.
आप लोगों को दिखाई दे रहे नहीं है. So I don't know whether you're reading from a book or you're answering me. Yeah, that is better. Correct. Sir. Now you speak.
So in blood analysis, sir, we will have to measure the serum level of calcium, serum uric acid, serum intact parathyroid hormone level, serum electrolyte levels, sodium, potassium, and arterial blood gas analysis. Arterial blood analysis will yes, sir. We will want to know.
So now if the patient is having high intact PTH levels, what do you feel that is?
If PTH level is high, sir,
patient has come and
yes, sir. So if intact PTH is high, it could be a case of hyperparathyroidism. Now this hyperparathyroidism could be a case of primary hyperparathyroidism, or it could be a case of primary hyperparathyroidism, or it could be a case of secondary or tertiary hyperparathyroidism. So if if patient is having increased serum calcium along with increased intact PTH, probably it would be a case of primary hyperparathyroidism. So along with intact PTH, we would like to know the level of serum calcium as well. And
fine. And what investigation you do to look for the PTH high levels?
For PTH high levels, along with serum calcium.
No, serum is done. Is there any other investigation to look for the parathyroid hormones?
Yes, for yes, sir. We would like to do USG next, sir. USG next will tell us about tell us about the parathyroid adenoma if it is there, but the sensitivity of USG neck is not 100%. So we may need system EB scan to look for the parathyroid gland, sir.
Very good, sir. Yesterday, in the last end of our discussion in class, Dr. Puneet elaborated something on RTA. What is RTA?
So it is renal tubular acidosis, sir. So
And
in
type?
this, yes, sir. So in this renal tubular, mainly there are of three types: type 1, type 2, and type 4, sir. Type 1, type 2, and type 4. Type 1 is distal renal tubular acidosis. Type 2 is proximal renal tubular acidosis, sir. And type 1 is mainly associated with formation of renal stones, sir.
And nephro?
The normal
calcinosis.
And nephrocalcinosis, sir, and renal stones, sir.
Zaid, what is a high PTH? What do you mean by high? What is the level?
Yes, sir.
What is the level of the PTH when you say it's high PTH? What is the normal level?
Usually, sir, usually we consider more than 2 or 3 times than its normal value, sir. More than 2 times. Yes, sir.
What's the normal PTH level range?
It is around 110 picograms, sir.
100? No, it's not more than 60, 65.
Yes.
And the calcium?
Calcium 10.5 milligram per deciliter, sir. 10.5 or 11 milligram per deciliter, depending on lab, sir.
What will be the phosphate level here? Where you are talking
yes,
about
sir.
Phosphate level.
Phosphate, sir.
Hyperparathyroidism.
Yeah, in secondary hyperparathyroidism, phosphate level is increased, sir. In secondary hyperparathyroidism, phosphate is increased, sir.
And primary?
In primary, it is usually in the normal range. In secondary hyperparathyroidism, it is usually increased, sir.
It's low.
In primary, it is low normal, yes, sir.
So what are the drugs? What drugs can lead to this thing?
Yes,
any
sir.
drugs can predispose to stone formations? You are aware of?
Yes, sir. Many drugs
can
give.
A lot of drugs and patients will ask you, Doctor Sahab, I am having this thing and I went to X person, he gave me these drugs. Are they responsible for stone formation?
Yes, sir. Many drugs are responsible, sir. Like a commonly used drug, Indinavir can cause stones, sir. Silicates, they can cause stones, sir. Laxatives, they can cause stones, sir. Different drugs used for COPD and asthma, they are also sometimes associated with stone formation. Steroids, they can cause stones, sir.
Common vitamin C levels, vitamin C, vitamin D, estolozamide and steroids. They are the common drugs which are used clinically, can lead to in excessive doses, can lead to the stone formation.
Vitamin D is a fashion now. So it's a vitamin D is a cause.
So what
Rahul, can I ask him one thing?
Yeah, please.
Switch from this one. I forgot to ask them when he showed the X-ray KUV. Looking at the X-ray radio opacity, what do you think the stone is? What are the different stones having the radio opacity? Just a quick thing, and then you come back to this one. Otherwise, you'll forget about it. That you could see two stones here, radio opaque. What are the stones which are radio opaque?
Let's show the picture of
calcium stones. They are calcium oxalate, calcium phosphate stones. They are radio opaque stones, sir. And uric acid stone.
And radio opaque?
Yes, sir.
Radiolucent and radio.
They are radio opaque. Uric acid is radiolucent. Indinavir stone is radiolucent. Trimterene stone is radiolucent stone, sir. Xanthine stone is also radiolucent stone, sir.
Yeah, okay, fine. So uric acid is the radiolucent. Other xanthine and other things are basically not radiolucent, but they have got a groundless appearance. So they are less radio opaque. Okay, fine. Let's come back to that one. Otherwise, I thought we'll forget about it. Well done. So
now, what are the urinary metabolic evaluation you want to do for the patient? What do you want to assess and when you want to assess?
Sir, for urinary metabolic evaluation, the patient should be stone free for at least 3 weeks, sir. After stone clearance, at least we should wait for 3 weeks. Then we should do urinary metabolic evaluation, and patient should be on his normal diet, normal dietary habit. Only then we have to advise the patient to be on his normal daily dietary habit, and then we will collect urine for 24 hours, and then we will evaluate urine for 24 hours: calcium, uric acid, oxalate, cysteine. These we will evaluate.
No, cysteine is not there. Na? Cysteine, you don't usually evaluate for cysteine. In India, you don't evaluate. In the panel, cysteine would not be available. Calcium, oxalate, citrate, uric acid, and one thing is more.
And pH, sir.
Magnesium.
Magnesium, yes, sir.
Magnesium, exactly. So when you do this, how do you tell your patient how to collect the 24-hour sample?
Patient the first voided sample the patient will discard, and then from the second sample onwards, and the next morning the first sample that will be included in a container. That container should contain the preservative.
Exactly. So he has to go to the lab. Yes, and get that container to that. Because otherwise,
is provided by the the container is provided by the lab, and that container contains preservative, sir.
Among all these things, which are the stone aggregators, facilitators, and which are the stone inhibitors?
Sir, magnesium is a stone inhibitor. Yes, sir. Magnesium is a stone inhibitor, sir. And citrate is a stone inhibitor, sir. Citrate is also a stone inhibitor.
Citrate comes first, and then the magnesium. You said the right thing. But
you are speaking right, but exactly. Then this is now distinction. You are going towards that level now, Zaid. You have answered everything very well. I'm very happy. So nothing much to discuss. You know your subject, but citrate first and magnesium second, because commoner thing first.
Yes, sir.
And there are stone inhibitors. They are stone formation inhibitors, and rest calcium, oxalate, and uric acid are stone aggregators. So they facilitate the stone formation. In addition to that, what do you check in the urine? उससे पहले 24 hours से पहले, what do you?
Hello, your voice is interrupted, sir. Hello.
Okay. What?
Yes, sir,
now it is clear.
Yes, sir. Yes, sir.
Am I clear now?
Yes.
What do you check in the urine before doing a 24-hour urinary analysis? What is easily available?
Volume of the urine, sir.
No.
And
no.
Simple test. What do you want to do, which will give you more information? Also add to the information what you are going to get in 24 hours.
Urine routine and microscopy, sir.
Routine urine. What is important in the urine routine?
Sir, urine routine would like to look for pH of the urine, sir.
What is the normal color of the urine?
Amber color, sir. Amber color.
Good. Yes. Very good. So what is the normal pH of the urine?
It should be, sir, 4.5 to 5.5, sir.
Huh? 4.5 to 5.5 is the normal pH of the urine.
6.5 up to 6.5. Up to
6.5 is approximately normal urine.
Up to 6.5
is acidic. Anything below 6 is acidic.
Up to 6.
तुम vaginal pH में चले गए थे. You went to vaginal pH. ऐसे on a lighter vein, I'm just.
Okay,
6.5, sir.
6.5 is a normal, approximately 6.5 to 6.7, something like is a normal. Below 6 is acidic. Beyond 7 is alkaline. And
alkaline, yes.
Third is urine routine. Mein, one is the color of the urine. It should not be double, amber color. Second is the pH. Third is
we have to look for, sir, crystals, different crystals in microscopy.
Before crystals. Very important to diagnose your RTA. Diabetes insipidus. What is that?
Osmolality, sir. Osmolality of the urine.
The specific gravity of the urine.
Yes, sir.
1010.
That is very important to know in a recurrent stone formers. And that information is easily available before your 24-hour urine comes from Delhi and Bombay. Okay. So this is important. And then urea, what sort of crystals you are finding, and what are the crystals you've seen in the urine?
We can see crystals of calcium oxalate monohydrate, sir. They are of dumbbell shaped crystals, sir. Calcium oxalate monohydrate. Then calcium oxalate dihydrate crystals, sir. They are tetrahedral in shape, sir. Bruchide crystals, they are needle shaped, sir. And struvite stones, coffin lid appearance is there, sir. Cystine crystals, they are benzene ring like, sir.
Okay.
Uric acid is amorphous, sir.
Cystine is the other important concept about a bilateral recurrent stone is this. You have done very good evaluation. Just one more test, and then I am done with you. What test would you like to see in your patient?
Functional study, sir. Which kidney is better?
That is already discussed in all the cases. I'm not going to find more important. What can lead to the recurrence of the stone? We're discussing recurrence. One is metabolic evaluation. Second is infection.
You have told,
yes, sir.
So if it is a recurrent infections, that can precipitate the crystals and you can form stones again. So you have to tell your patient after you remove the stents that he follows up after 1 month with a simple routine test and do a culture on him. And ask him to check the specific gravity of the urine. He should do a dipstick test to nitrite test. He can do it at home once in a month or once in 6 weeks to see there is no underlying infection which is resulting in precipitation, change in the pH and crystallization. Good, Zaid, good. I am done with him, Harpreet.
Because after you have done a very successful PCNL of a staghorn, and after 1 month he comes back again, that the pelvis is full of stone, that's the infection. So that is very important. That can cause very rapid recurrence of the stone. You have to keep in mind.
Yeah, just very important. Let's follow the basic. We are not here interested in a very big thing. As so, you have rightly mentioned stone analysis, metabolic study of urine. You are absolutely, you have discussed all the points. Third is infection, as everybody has emphasized on, and the fourth is any anatomical obstruction. These are the four things which are very important. No anatomical obstruction, no your infection, metabolic, and your this stone analysis. So these are the four key points where we can work it around, and we can see further. I answered very well. So
just check with the lab. I think 24 hours urine, that preservative they use the boric acid. Just check with that one. For your
HCl, sir. HCl, hydrochloric acid.
Boric acid, or is it boric acid? Just check with the lab. I'm not very sure.
Sir, earlier what we used to do, when our times we used to collect into one for oxalate and citrate, used to go to another bottle of hydrochloric acid, and the other preservative used to go for all other fours creatine. But now what I see with the lal pathology, they in one sample, and they take it in one sample with it. And you asked about the preservative, na? Boric acid, I think it's HCl is there. I'm not sure about the
check with the lab. You have done so well, so you should know this one as well. Just check with the lab and you will know.
Okay.
I think it is done. This is over.
So we will save some time. We'll go to the last case. So last case, what I'm going to do is last case on complications. I think Rahul has discussed complication. I'm just going to give a scenario. I'm just going to share one slide with you. Nitish, can you stop sharing? So I'll just share one slides so that we can discuss about the complication, and then we can wrap up the session early and allow everybody to enjoy the Sunday morning. Whatever left of the Sunday morning. So can you see my slides?
Yes, very clear.
Okay, so this is a 69-year-old male, no comorbidity, pain on and off left flank, came for further treatment, renal function normal, urine culture normal. And this is the stone. You can see this, the stone bulk is there. And
this is the IBP of the patient. What do you feel, what is the Guy score of this IBP? Stone's Guy score. Yes, sir. Now looking at this KUB and put that IBP, Harpreet.
Yeah.
This is the IBP of the patient. What do you feel is the Guy stone score for this patient? How do you score? How do you, basic purpose of any scoring or any investigation, anything is to see whether the stone would be complex or it will be simple stone, and what complications you have to explain to the patient and the attendants. You know, you have to explain them. You're not God. You're not God, and you're not a जादूगर के आपने हाथ में निकाला और stone patient को पकड़ा दिया. So whenever you are going to intervene, some problems can happen. That can happen anywhere. So the basic purpose of doing investigations is to gain the knowledge and tell the patient, by this is the probability and this can happen to the patient. So what is the Guy score of this thing? IBP, if you are following, yes. If you are following, no, let me know. So you know what is the Guy score?
Exactly, I don't remember at this time, sir.
Fine. There are 4 scores for this thing. So I think you go back, and now after the class, first thing you'll read is the Guy stone score. Okay?
Yes,
this is a partial staghorn complex stone.
Yes.
So what complications do you expect? What would you explain to the patient before you taking up the patient for PCNL in this stone?
Different complications of PCNL like hemorrhage, sir, bleeding.
Hemorrhage, what is the percentage? The patient will ask you. Okay, doctor, no issues. What is the probability of hemorrhage?
It's, sir, in around up to 20% of the patient it has been reported, sir. Hemorrhage.
Up to 20%, depending on the complexity of the stone. Usually 1 to 5%.
Yes.
Okay.
Sir.
And the patient will ask you, should I arrange blood? What is the probability of blood? What is the percentage of the patient who will require? There is, see, understand. Having a hemorrhage is different. Need for blood transfusion is different. So what is the percentage of the patients in PCNL who require blood transfusion?
5 to 20% of the patients, sir.
So hemorrhage and blood transfusion rates are the same?
No, sir, they are different, sir.
You said 20% for hemorrhage and 25,
yes,
5 to 20%.
5 to 20% of patients need blood transfusion, sir, after PCNL, sir.
And need for angioembolization?
Angioembolization that is needed in around 1% of the patients, sir. Very
less than 1%.
That is
Okay.
rare, sir.
Less than
yes,
okay,
sir.
fine. Chalo, next. Harpreet, आप बता दो next क्या हुआ?
So let me share with you, because I did this patient yesterday and I had
this is a complex stone.
It's a big scale. So it's a complex stain. So you can see this picture. So this was my area of puncture. So I went with this puncture and thinking that once I will fragment this, I will come to this, I will pick up the stone from here, and then it should be easy. If you can see this stone, this is here, and this one is here. So I went to this and I thought I will pick up from this. This was my game plan. But as Rahul had asked, I anticipated problem in this case. So I arranged 2 bottles of blood. Generally, I don't do any PCPL without blood. This is my principle. You may agree or may not agree, but this is all right. So I arranged 2 blood for this. So when I went from this case, so it is fully packed stone. So when my ampullus was at the edge of the stone and the oozing occurring during the surgery till I make some space to enter it. And surgery time was 1 hour. I kept a nephrostomy and I clamped because of the blood at the edge, and BP was stable. So what happened when I went there? So I finished this stone quickly. When I went from this stone started from lower calyx coming above, and we finished this and we finished this. Then I realized that this was actually an overlapping calyx. I pulled because on CM I see one fragment here. So what I did, I bring my ampullus a little out, so I was able to enter this stone impacted part and able to remove it. But I can see an opening of a small vessel here, which I can see it is peeping at me. Anyhow, when I put the nephrostomy, there was blood in the nephrostomy. I just clamped it. BP was stable. Pulse was 76, 120, 70 BP. He had a small dip of 104, but anesthetist told it is not because of the surgery. So anyhow, doesn't matter. We shifted the patient to HDU. So with this, and I got both the bloods immediately. I didn't want to take a chance. It was a Saturday, so I told, let's not take a chance, get the blood and start one blood. So this is a nephrostomy clamp. After 3 hours, the sister who has assisted me sent me this picture that this is the picture. Well, what next? What do you expect and how do you move from here? All 4 of you can take this question. Anybody wants to take this question ahead? This is the picture I got after 4 hours.
Patient is having gross hematuria, sir, and we will have to look on the vitals of the patient, sir, whether the patient is maintaining his BP and pulse rate or not, and we should transfuse blood, sir, at this stage. And initially we should give a conservative trial, and later on we may plan a CT angiography in this or angiography in this patient, sir.
Zahid, you tell me what is the indication for intervention? Like you said, I like to do a angiography or
later on, sir.
Later on, CT angiography. CT angiography.
Angiography, no sir, angiography, but later on, sir.
No, but my question to you is, what are the indications when you say no, I will not wait, I'll proceed and do this thing early?
If the patient is not maintaining vitals, sir,
second.
Yes, sir. And if there is persistent drop in hemoglobin, sir.
What do you mean by persistent drop in hemoglobin? Which is what, when you say the drop in the hemoglobin is significant drop. See, what happens is once your patient's bleeding, BP is fluctuating, you push in a lot of fluid. You push in a lot of fluid to compensate for that.
Dilutional. Yes, sir.
I will not give you exact number. What is the definition of? See, when you say significant drop, what do you check, and what do you mean by significant drop?
We will look for hemoglobin along with hematocrit, sir. Along with
hematocrit is more specific than hemoglobin, and the drop of this from this to this is considered to be significant. What is that drop?
Around 3.5. Yes, sir. Around 3, sir. Yes, sir.
Is considered to be
3.5.
Or
significant.
So this is drop. One is a hemodynamic stability. Second is drop in hemoglobin. Third is what is third point? We can see this. See the color of the blood and the thickness of the blood. What will happen to him? What can happen to him if you are not using an irrigation? What will happen?
clot retention could happen.
Yeah,
sir.
so if the patient is having recurrent, one clot retention is not an issue. If he's having a recurrent clot retention with previous two factors, then again you are pushing the patient faster towards angiography rather than waiting on him.
Yes, sir.
Okay. Fourth is, it's a grade 4 renal injury.
Yes, sir. Yes, sir.
You should palpate the flank of the patient. Sometimes you can find that it's quite full and quite tender. It's not uncommon to have that, because you see, PCNL procedure is, it can bleed. PCNL is only one thing PCNL can happen is bleeding. The rest, nobody is afraid of anything in PCNL. So this can happen to anybody. Even you do, see, he's put a mini PCNL. I think iska jo tube hai, this is hardly 18 French tube hai jo Harpreet ne dali hui. So,
Yes, it's a
so this can, so this myth that minis don't bleed is a wrong myth. It's a wrong myth. Any PCNL can bleed. So anyways, that is besides the point. So these are the three basic factors which should push the patient faster towards angiography and angioembolization. Plus, if the patient is, all the three things are reversed, like hemodynamically getting stable, his hemoglobin is not falling, he's not developing clot retention, there is no flank pain, there is nothing, that patient you can wait on these patients and keep them under strict observation.
Yes, sir.
Okay. So, and what is the color code of this thing? Yesterday I told you, I showed a paper.
Yes.
Yeah.
It appears to be grade. It appears to be grade 3.
Grade 4 or grade 5?
Grade
5 नहीं होगा, because you have not gone to pelvis and gone to the renal hilum. Hilum फटेगा तब, then it's grade 5. So it's not a grade 5. This is more of a grade 4 injury.
So when this picture came, I was not in the hospital. I was in clinic. So as Rahul mentioned, seeing this, anybody can get frightened because nephrostomy is clamped. When I left the patient urine was like pinkish color. What is generally it is there, because this color was I finished the surgery at 9 o'clock, 9:30 I left. Patient is absolutely all right, and 12:30, 1 o'clock I get this picture from the hospital. So as Rahul mentioned, so there was really a panic situation. For the first thing I did, I asked them to keep the theater ready. So for what I asked the patient to keep a theater ready? I don't have any sort of angioembolization facilities. So I asked them to keep the theater ready, and I asked them to empty the urine bag. So what you will see when you empty the urine bag? Gareth, what you like to see when you empty?
Any fresh or active bleeding we can see, sir, after emptying the urinary bag. Whether the
you may not be able to empty the bag.
Rahul ask this question. What do you see?
Empty the bag because there are a lot of clots inside the bag. You may have to put a fresh bag.
Yes.
So when I emptied this,
clotting is happening into the bag, and you.
That's the disproportionate part. You see, I mean, the patient is quiet, not restless. There is no flankness. The BP is relatively well maintained. Hematocrit is not that much falling. So you have to focus your attention to the bladder. Already there have been blood bleeding during the PCNL, and the
exactly. So he's a compensated patient. He's a compensated patient.
Compensated patient. So you give a good power wash, and put a 3-way catheter, and then assess the whole thing.
Young patients can tolerate bleeding better than the slightly older patients and comorbidity patients.
So seeing this sister and old male, no comorbidity. It took 1 hour, but I can see the bleeding. So what we did, we empty the bladder. But very good thing, we noticed that there are no clots in the urine bag, and that it got emptied immediately. And his pulse was still 80, 82. I checked manually, pulse is looking good to me, but though the patient was pale. So what we do, seeing the BP is good, but at that time BP was something like 172/76. We given him 10 Lasix at that point of time, emptied the bladder. And patient was also started at that time, and this antibiotics was only ceftriaxone and gentamicin 160. That's what I have given pre-op. So the idea was that when you see such bleeding, and we did this first, but let's check whether his pulse BP is rising or not rising. So with this, I think Rahul has discussed some point. Let me show you something. So this was after 20 minutes of giving Lasix. This was his urine, and this I'm showing you there. There are no clots. His pulse might be fluctuating between 82 to 83. I thought कि इसको pacemaker तो नहीं, एकदम fixed type का pulse आ रहा है. I thought the pulse is not giving a correct picture with that. But this was the intent, and patient want, I'm feeling hungry, I am feeling good.
No,
so
I'll stop you. For a resident, it is very important that to me, the pulse is the most important criteria after any major surgery. If a pulse is stable, it is not bounding, the volume is good, you are rest assured there's nothing major is happening. If it's tachycardia, the pulse volume is fluctuating, this is the first indication that something is wrong with the patient.
And especially two things we notice. One is the restlessness. If the patient is quiet, nothing much is going on inside. Number two, look at the back. There is ecchymosis in the back. Sometimes you do not look at the back and there is a black discoloration. That means there's a collection in the retroperitoneum which is coming out. It shouldn't, get unnoticed. But as Hardik was saying, the patient is quiet, pulse rate is good, the BP is not filling, so you can give a chance and no rush of going for doing a nephrectomy or whatever it is.
Yeah. Actually, Shivaji, I actually told that I keep the theater for nephrectomy because I don't have this facilities. I have two things in mind. If it will be hemodynamically unstable, I will go immediately and I will just do it. If it's stable, then I might look at the place where I have done the surgery. If I can give 1 or 2 quick stitches there, if there's a bleeding from a vessel, which has seen during the surgery. But any of this was I did discuss with what is the idea to discuss is post-PCNL bleeding is very common. Don't get panic. If the patient is stable, look for the vitals. Vitals are very important. See the output. When giving Lasix, I was little thinking debating whether to give or not to give, whether I will further bring down his BP and it will keep you more trouble. But saying everything, when I emptied, there was no clot inside. So I thought it must be a venous ooze and we should proceed. But if now this scenario is settled, suppose if the patient continues to bleed and the hemodynamically unstable, and you don't have any facilities of at your center or the nearby center which can do the renal embolization, what you will do next, Jayad? What you will do if you don't have any facility?
If vitals are not stable, sir, I would like to do angiography, sir.
And you don't have facility for angiography.
Then, sir,
your center doesn't have facilities for angiography. Then
we will have to keep in mind the option of nephrectomy. If life-threatening condition arises, then we have to preserve the life compared to preservation of organs, sir.
So, what is the percent of the patient who undergo nephrectomy post-PCNL?
Nowadays, most of the cases they can be managed with angiography and angioembolization, sir.
Correct. So, you have done angiography, you done angioembolization, patient stable for a moment, then again patient started bleeding. Let's put it this way. You did angiography, you've seen one pooling, you have put a platinum coil, you have again come back, and after 2 days, patient again started bleeding. From where is the bleeding?
Second post-operative day, sir.
Second post-op day, again there's a fresh blood in the Foley's catheter. You can see it's a fresh blood. There are some clots also, and patient is requiring blood transfusion.
Delayed hemorrhage,
so what you will do next?
Again, we will do angiography, sir.
So do it. No, you have do a bedside ultrasound. See where you were earlier having a
stent or coil, sir.
You put whether there's a pooling of the blood or there is no pooling of the blood. Is there any collection? So when you put a blood ultrasound, it will show you, Doppler will show you there is no pooling of where you have already put a stent. Then what you can see, you should there can be two reasons. One, either the blood vessels which are there, they So one is that, or you can see, you should also see the tract. Sometimes bleeding is from the tract, and tract bleeding sometimes does bring the patient to hypertension, and it sometimes goes because you have hit the intercostal. I think if you've seen Rahul's presentation yesterday, he has shown the intercostal vessels injuries as well as the muscular injuries. Sometimes it does happen, and that bleeds keep on seeping. Second thing, and the other thing is, you're right, you can do again, go for a angiography. And what precautions you will take, or what extra thing when you do angiography at this point of time?
Sir, we will look for serum creatinine, sir, fresh serum creatinine of the patient.
Serum creatinine normal. आपने एंजियोग्राफी किया, आपको कुछ दिख नहीं रहा है, what you will do? So use papaverine. Sometimes blood vessels are into the spasm. Sometimes when there is a bleeding from the kidney and you're looking for it and you're not finding, sometimes it's a spasm. Giving papaverine at that point of time to open up that spasm, wait for some time and look for it, whether there is anything. If it is still not there, so you did angiography, you did papaverine, you found that the coil which you have done is good, you're not getting anything. What next? Now what next? What you will do? Think of it. I have already given you a hint.
It might be bleeding from intercostal vessels, sir, or from the tract site muscles. Muscular. The source of bleeding after PCNL is not only the kidney, sir. The puncture site, the muscles, the intercostal vessels, they all could bleed, sir. It is not only the kidney or renal.
What you will do? Tell me quickly.
Yes, sir.
What you will do now, because patient part is क्या operation कर दिया, आप 2 बार operation theater लेके गए, doctor साहब कुछ कर नहीं पा रहे हैं. He has created a crowd of 100 people outside your hospital, and what you will do?
Nephrostomy tube is in place, sir.
Nephrostomy is removed. Even if it's placed, what difference does it make? Nephrostomy is not draining.
Yes. We can fulgurate, sir, but
how will you fulgurate?
We can fulgurate. The tract fulguration could also be attempted.
How will you fulgurate the tract?
Using electrocautery, sir.
So how will you see the bleeding from the tract? So, Jayad, this is the time you will take a consent for a nephrectomy, and you will go inside. You will. That's why I asked you what percentage of patient undergo nephrectomy. So you'll take a consent, and when you're taken a patient to the operation theater, your BP is fairly stable. It's not very unstable. You arrange your blood, you open, and you try to see the tract from from which have gone inside. You can use a Doppler. It really operative Dopplers help at that time. And at times, if the bleeding is from the tract or just at the renal capsule, you just give a stitch and you can avert it. And the moment you give it and you do a Doppler, you will not find anything. And if you don't have this fancy gadgets available, if you're able to see and do it, you can take a stitch. Otherwise, you will do nephrectomy to save the patient. So less than 1%. Actually, data is 0.3% of if you take all scenario. But very, very rarely you keep in this mind, and a patient might need nephrectomy to save it. And if you don't had every scenario, the first slide which I showed you, if it is bleeding like this and it is continuous, hemodynamic unstable, just open it like we used to do for the, if you remember your MS day for the splenic injury, you just put in and then just clamp it. You don't have to bother about the superficial brain, because if you will not do it, you will lose patient. They lose blood like so fast. So any day, any renal thing is always bleeding is very, very important point. Sir, Sivajida will like to add something on this.
That's fine. I think that nowadays, I think we can send you to the referral center for the angioembolization, because that saves a lot of time. Now, they are usually selective embolization because they find out what is the source of the bleeding and put a coil or a gel foam on that part. And the reason for second bleeding is because of the dislodgement of the coil or the gel foam. Then they will go and do the total embolization, which means a medical nephrectomy, basically. So that part is fine. And as Harpreet said, that if there is no facility, then we take a consent and go ahead. But still, you can sometimes put a stitch on the lower pole on the tract side, and sometimes you can stop the bleeding with a bit of luck. or lower polar thing, or take the kidney out if this is a life-saving. I mean, life is first, organ is second. So, but nowadays, angioembolization, you have to tell them, in the exam, if necessary, to send it to the nearest referral center to do that one. So stick to that one. If not, if the dire situation, you cannot even move the patient. You have to go take it to the theater and do the nephrectomy if the pressure is falling. So that part is all right. And if there is a chymosis in the back, that sometimes signifies more a tract bleeding because it is coming out to the side of the tube. And the second chance of bleeding is to the medial wall of the pelvis, where you hit, the stone hits, or your nephroscope hits, and there is a tear on the infundibular vessel. That will not be stopped by putting a stitch. Then you have to take the kidney out. So I think that Harpreet's case was an example that you don't jump into that one. If this bleeding with the first you saw could have been a bleeding during the procedure. He bled during the procedure, fair enough. But that is not a continuous bleeding, and so there's a bladder is full of clot. You take the clot out and put a 3-way Foley catheter, see the irrigation for some time, but keep watching on the vitals. If there is a panic, go straight away and take the kidney out after counseling.
Rahul, is Rahul there? Sandeep and Nitesh, for your comments. Sandeep, are you there?
Hello.
Yeah, Nitesh, please give your inputs. Nitesh, we can't see you.
Yes, sir.
Yeah, give your inputs. You like to add something to the discussion?
If after Lasix, if this is the urine, if it is clearing up, I would like to wait. And sometimes flank compression also works well.
Good. So we did put a Dana Plus. Before that, it was just a simple dressing. We did that, and we kept it pressed that time. Actually, it helps immediately after the surgery, and when you have such sort of immediate bleedings, it does help sometimes. Yeah, you can do that. Literature does have some support on that.
But Harpreet, I want to add that Dynastrap strapping may not help. What is important on the table, if there is a more than your desired bleeding, then you put a 500 cc of a normal saline under the flank, and then put a pressure for 3 minutes from the back. That gives a pressure, bimanual pressure can stop some bleeding there. So that there is more than average bleeding.
This is more better than, and that has to be done immediately, if you see, because immediately there was no bleeding, so it didn't require that. But after that, once it started, we don't know after that time putting bimanual compression is going to help or not to help.
No, it does not. It does not help. It will not stop the bleeding. So the message to Zaid is that their bleeding can happen. It is a common complication. The incidence is around 20%. You should be always arranging blood. The blood need for blood transfusion is fall in the hemoglobin, hemodynamically unstable. If he has lost, the surgeon would know. So there is 10 ml blood loss. If the vision is not clear, so he is losing more blood. Longer the surgery, more the blood loss for PCNN. This is important point you have to understand. Put a PCN, put a stent in such patients. It is indicated to put a stent to prevent them from clot colics, and have patience. If the patient is not doing well on expected lines, go in, intervene early rather than making the patient unstable and doing. I think
sir,
that is.
Sir, I have one question, sir.
Yeah.
Sir, in solitary functioning kidney, if PCNL has been done, so are the same criteria for angiography should be applied for solitary functioning kidney, or we should keep our threshold lower, sir?
No. Solitary functioning kidney or non-solitary functioning kidney. The criteria for intervention remain the same. You don't have to rush because you don't want to do harm. You don't want to delay because again that will lead to the harm. So you have to be very critical of this fact that the patient is unstable. As soon as you talk to your radiologist friend and prepare him, keep the theater and everything ready, and if required, immediately intervene. Solitary or non-solitary should not make much of a difference. The only thing is that in solitary kidney, what sort of a painkiller you are using, you should be very much concerned about that. And aminoglycosides. Like we said, we have given one shot of this thing. Even if we feel that the patient is partly sepsis sort of thing, a minor glycoside should be guarded, because these kidneys, when bleed, they go into a shutdown. Obviously, they will go into shutdown. And in that case, if solitary kidney is there, then you will have more trouble with it. So you should be aware what sort of antibiotic, no nephrotoxic drugs should be minimized immediately.
Yeah, I forgot to mention, I stopped the aminoglycosides, I stopped ceftriaxone, I changed it to a higher antibiotic. At the same thing, one more thing, forgot to tell
kidney
you.
doesn't make much of a difference, but solitary kidney does.
But solitary kidney, Dr. Zaid, what you asked the difference is that you have to be very proactive in the solitary kidney in getting a selective embolization done. Because opening up, it ends up with a nephrectomy, nothing short of that one, if you have to open up. But solitary kidney, if there's a good, you see the problem during the 48 hours, it doesn't cause a heavy fistula. So that's why it is not, with a fistula, you can miss on the angiogram because the dye is washed out. But in this sort of cases, as there is no time for a fistula that way, always the selective embolization, they will pick up the bleeder and can put a coil and gel and try and save the kidney. That's a solitary kidney. You get your utmost effort, if necessary, to get to the next immediate referral center. But if there's one kidney and the patient cannot afford, then you have to wait. If there's a vitals are falling, you take to the theater. There is nothing there.
Role of tranexamic acid, Dr. Rahul, will you like to add
not for major bleedings? Not for major bleedings. It's a literature suggests the use of tranexamic acid to reduce the blood loss, but this is a surgical bleed, and whatever is a surgical bleed, this bleed is usually main infundibular vessels which are torn. There is no role of tranexamic acid in these cases. You have to go and intervene for these cases. If it is a large stone, you have done a stack on EZUSI pelvis, then you may use tranexamic acid, but otherwise it is not going to help.
Rahul, I agree with you completely, but the EAU guidelines, tranexamic acid is there. So there's no harm for the minor
bleeding. Minor bleeding, but that's what I'm saying. Said minor bleedings would either stop. You can use but if the patient is getting unstable, don't rely on you.
Of course. As I said, because of the EAU guidelines, so they will not be brushed off for that one. So you can try in a minor bleed. That's put a point on that.
So whatever conservative means we can think of, like watching the BP, arranging the blood. We started also one precaution: don't start it with the blood. If the blood is going, don't give it. So it has to be 15 minutes after or before blood transfer, and give some fluid before that. So minor bleedings or capillary ooze, they say, is canned. It cannot take care of major vessels. So whatever I can think of as a conservative measures, but as mentioned, it can take up only minor vessels or the capillary. It works. In fact, they say that if you want to stop bleeding, you have to give it beforehand rather than after the bleeding. Generally, after the bleeding, it's very difficult to get the
whatever papers are there before this thing, and they have found that the blood loss is less. So they are before for this thing.
Yes.
Okay.
Yes, there are a lot of studies in the TURP. I think one presentation was from Dr. Shivaji, the group also from the Fortis, from the large prostate. They were done a lot of studies on this, and they have injected. So I think this brings to the end of our discussion. I thank all my panelists, Dr. Rahul, Dr. Sandeep, Dr. Nitish, our experts, Dr. Shivaji Da, and Dr. Pal sir, who is not there, I think has left, and he told me that he will leave. So I thank them, and all the students participated very nicely. And I thank Ranjan Da for giving us this opportunity. Our President Ranveer sir, who has sat very patiently for the whole program and listened to us and gave his input. Before we end, I'll ask for final input from our President, Dr. Ranveer Prasad, and Dr. Ranjan De, and then we conclude the session. Ranjan Da, I think we are ending before.
Hello.
Before time.
No. I was leaving it, but I thought my roll call will be there. Definitely, I have to come back. So I was going to OT, the emergency, but I said I will come back just to say hello. I think we had a long and fruitful discussion, and always in the beginning I also said always have approach on the practical. We are here not to discuss our own problem, but we are here to guide a young man who going to become consultant. So wherever there is confusion, that should be set aside. This is the thing you have to tell in the exam, and that's all. Whatever has come, this is the picture you have seen, but at the end of this, we have to give the final message to the students. This should be in our mind. Otherwise, they will all get confused. A long discussion, everything is a long discussion. So we should be very clear while taking a class or giving information to our students. Thank you very much, everyone. Nitesh and Dr. Rahul Gupta, Dr. Shivaji Basu, and all the students. They are very enthusiastic and energetic. Thank you so much. We'll meet next week. We can close the meeting.